Right, good morning, ladies and gentlemen. Welcome to our April board meeting. Just checking sound levels. Is that everything working appropriately? Yeah, thank you very much indeed. We're now being recorded, aren't we? So we welcome the public who are joining us online as well as those in the room. First of all, can we take any apologies for absence, please, Peter?
Chairman, yeah, just apologies from Rachel Oden, Chief Medical Officer, and Steve Lennox, our Improvement Director.
Thank you, but we have some welcomes as well. Richard Quirk is here for the Chief Medical Officer, so thank you, Richard. Simon Bell, to welcome to his first public board meeting, our Acting Chief Finance Officer, so again, welcome Simon, but I think you've been to quite a few board meetings before, so you should be quite used to the routine. We've also got Sarah Wainwright, who's joined us as our Chief People Officer, Interim Chief People Officer, so welcome Sarah. We're very pleased to see you and wish you every success over the next 12 months, so thank you. Also in the audience, we have Stephen Broomhall, who's going to be joining us at the beginning of May, I think it is, as our Chief Digital Information Officer. So again, a very welcome addition to the team at CCAM. So thank you indeed for being with us today. We've also got in the order Stephen Mardlin, who's a new prospective governor, one of our new governors, who's site manager at Worthing Hospital, who's going to be joining the team shortly. He's one of our governors. Just to conclude, is that all in terms of our new arrivals?
Yeah, and of course, Usman,
of course, is in the audience as Chairman Designate, and Tina is here in support of Sarah Wainwright as well for the culture item. So I'll say a full house this morning with some new arrivals, but I hope you'll agree, a very detailed set of papers with a culmination of some very good work that's been done over the last 12 months. Right, let's move forward. Any declarations of interest? Anyone, any pecuniary interest or otherwise in the business being discussed? Okay, thank you. Minutes of the previous meeting of the 8th of February. Are you happy with the true and accurate record? Okay, thank you. We can sign those off. Peter, the action log, please.
Yep, Chairman, so the actions as stated are either closed, covered on today's agenda, or scheduled for future meetings. Thank you.
Thank you indeed. Moving on then to just the Chair's report to set the scene for the meeting. Just to remind colleagues, the key source documents are in the pack. So in terms of both the quality report and the board assurance framework are there to point the direction of questions, discussion of the meeting. We don't go through them page by page, but they are very important source documents to use to ensure that any questions or challenges are focused. And I think it's also very important, meeting, the point of view we're going to be signing off all being subject to the views of the board, our new strategy, which has been the culmination of some very, very good work both within the organisation, but also with a wide range of our external partners, and also with very detailed reports on the staff survey, which again is a very detailed explanation of how our staff are feeling. Generally, I'm pleased to say, more positive than they were feeling this time last year. Very positive report, and so there's again some very good things to build on there. In terms of one or two key items to pick out, as it were, in terms of my report, I think the staff survey, first of all, those of us who have been on this board for a while, it's been one of the continual sources of frustration that we've never quite managed to seem to be on the right page with our staff, and to have albeit with work to do, to have a positive report in the way that we've seen improvement across all of the headings, I think, as we'll hear later in the meeting, is testimony to the hard work of the executive team particularly, and those in support of them, those leading the organisation, that our staff are now beginning to feel engaged and supportive of the direction of the organisation. And given where the health service is currently in terms of the pressures on the service, that's a very important result. So I think that gives CCAM some hope for the future, I think, and something work that can be built on. I've also made reference to the Council of Governors in the meeting, and we've had a good meeting with the council since we last met as a board, and they're actively also engaged in planning, not only in our strategy, but also in terms of bringing some outside challenge to how we're beginning to tackle what's looking to be a very challenging financial round. You'll hear more from the Chief Executive and the Chief Finance Officer in due course regarding where we are, and we still haven't concluded the discussions for the 24-25 contract round. But I think anyone that observes the national media, but also is a follower of health service business currently, will know the health service is challenged financially, and next year promises the year we just commenced, but we're still concluding the contractual arrangements, does promise to be a particularly challenging year, and I think it really beholds all of us to really focus on the detail, and whilst we could only touch on it in general terms today, there will be a meeting in May when we'll need to sign off the plan for 24-25. Be the assured public meeting, but we need, which we wouldn't normally have, but because of the planning timetable, we will need to meet at that time to sign off the plan. But there's a lot of work to be done in the meantime. The executive team, led by Simon, are fully engaged in that, and I say it promises to be a very challenging time. And finally, I think may I say, this is my last formal board meeting, although there might be a brief one in May to sign off the budget. I just want to just end by, I'm sure there'll be other times for farewell speeches, and I don't want to go into a farewell speech now, but I do want to pay on public record, acknowledge the executive contribution over the whole 6 years I've been here, the contribution of the executive past and present to trying to get this place into a good order, and I hope the board papers reflect that we are now beginning to turn the tide in CCAM, and there is real hope for the future, not only the way the board works, but also in the results we're seeing, staff survey, financial performance, the other quality measures we have, our ARP, Ireland's Response Programme performance, where we're actually genuinely helping patients. And I think to me, that is a sign of a healthy organisation. So thank particularly the executive team for their contribution, but also non-executive colleagues as well over the last 6 years have been, steadfast, particularly in times of the more challenging times in our history over the last 6 years. So I've certainly welcomed their support. And I think it's only right that I acknowledge as well the support of some of our external partners, particularly Anna Eden, the Regional Director, who has been personally supportive, but I assure you extremely supportive to CCAM and what we're trying to do. So that has been helpful, together with our colleagues in the integrated care boards, again, who have also worked in partnership with CCAM. So thank you. I hope the meeting demonstrates what I've just said, that we are coming together as an organisation and there is hope for the future. So thank you for all that you've done. Right, can we move on? Because one of our key journeys back to being an improved and sustainable organisation has been the way we are led, and the external well-led review, which we initiated ourselves as a board to check out how we were doing and how was the leadership of the trust doing. And we have that well-led review before you, the final version. Peter, would you like to sort of give us the highlights, please?
Thank you, Chairman. So this is the final report the board's seen the various drafts beforehand, and the board's asked to effectively formally accept it as the final report. A reminder that this review was jointly commissioned with our NHSE ICB colleagues, one of the requirements of the RSP exit criteria as set out in the board assurance framework. I think I covered in the cover paper, we approached it deliberately as a developmental review to help assess our journey of improvement since the CQC's well-led inspection, seems a lifetime ago now, in February, March 2022. The recommendations in the report, there are a number are being used currently to develop our priorities for the coming year, and the board development plan for 24-25, both of which will come to the board at the next meeting in June. Overall, Chairman, I think we'd all agree that the review helps to provide independent assurance with the positive improvements the Trust has made over the last couple of years. But as we'll cover on today's agenda, it also reinforces the challenging year that lays ahead. Last thing to say is that after the board meeting today, there's a session to review the RSP exit criteria, so the board can agree the approach to the national RSP meeting, which is early in May.
So in summary, the board, the well-led review concludes where the board thought we were, an improving organisation with still work to do. Can I just check with board colleagues, because this is going to inform your work programme over the next 12 months at least, going forward. So can I just make sure, as a board, you're fully signed on to what's in here, that everyone agrees with the comments? No one feels slighted? No one feels that it's been supportive to your work? That it's a document we all own to completely, because as Pete said, it's reflected in the development programme and in other work of the board, isn't it? And the way we conduct the meetings and our committees.
Yeah.
So this is a full inspection in public of all that we've done. So well done to all those who contributed and helped on the journey, but also it's a template for the future, as it were. Okay, thank you for that. The Audit Committee. Michael, chair of the Audit Committee, your report, please.
I'll take the report as read. So there are only a few things that I'd bring to the board's attention. We now are at the end of the financial year 23-24. So the Audit Committee a few weeks ago sought assurance that our external auditors are well placed to complete their work to ensure that we can submit financial statements and an annual report as we are required to do under the statutory remit, and I can give that assurance. Two other points very briefly. We took the assurance report from our counter-fraud colleagues. Generally, CCAM performs very well in respect of this, in terms of we take our responsibilities very seriously to minimise the risk of fraud in the use of public money. One observation was made, though, that we could be better in ensuring that people attend the training on anti-fraud and how to manage this, and the executive gave a commitment that they would take that away and look to ensure that we improve performance. The board will be aware of the National Ambulance Resilience Unit review that we asked to be undertaken. That's now completed. The committee is assured that the trust has a good action plan in place to implement all the recommendations. As the Chief Executive has reported before, we have received additional funding. This is a key issue, and what we are proposing is that there will be a subcommittee of the Audit Committee that will look at progress in implementing the recommendations and give assurance back to the formal Audit Committee and the board, and I would recommend that action. The final point I'd say is, again, a lot of good work has been done on embedding and developing the Trust's risk policy and risk strategy. Observations from internal audit, initial observation was this is all very good, but clearly, as the Trust recognises, there is more work to be done, particularly in ensuring that risk management is really at the heart of our decision making, so that we make the best use of public money, but we ensure that clinical risk is managed and minimised. There's no underlying concern, it's just building on the good work that has been done already, and the Audit Committee will continue to monitor that. The one thing I will say is around culture, and I think we need to recognise that risk management is not just about preventing bad things happening. It's about creating a culture where the people within CCAM, clinicians and non-clinicians, feel confident they can be innovative, they can take on, they can take new decisions in the interest of patients, knowing that risks are effectively managed. And I think this is really, really important as the NHS continues to be challenged in terms of its financial position, and it needs to be more productive, it needs to look at new ways, it needs to adopt new technology. So risk management has got a really positive upstream impact if it's managed, if it's implemented effectively. But I'm confident under Margaret as our Chief Nursing Officer and her colleagues that that is being taken forward in an appropriate way. Chair, that's all I'd like to say.
Thank you. I think part of that as well is being innovative occasionally comes with risk, and occasionally things go wrong. And it's having a culture that by recognises things will go wrong, and when we do, we learn from them, and learn it's often a system issue, not the fault of an individual. And that's all part of a healthy culture we're trying to build here. So that's really important we emphasise that. Right, colleagues, are you happy to take the report? The Chair of the Audit Committee, have you any questions or comments on his report? Okay, thank you for that. Thank you, Michael. Let's move on now to the Chief Executive report. Simon?
Morning, everybody. So a few points for me to pick out. This is the pivot point in the year, so we are looking back and looking forward. So I'd like to start by just acknowledging that at the end of last year, which we formally tipped over during the course of last week, we were the second best performing ambulance trust in the country in terms of C2 mean. And I think that's something that everybody around this table, but more importantly, all of the colleagues right across the organisation should be rightly proud of, given the context of the year that we have just been through and all the various operational challenges that we faced. It's important, I think, we reflect and all congratulate our colleagues across the organisation for achieving that. It remains the signal marker of confidence in the ambulance service. None of us, I think, would see that as an end point, and we want to go further, and we'll come back to that conversation on the strategy and our hopes in respect of that later today. But I think it's really important that we acknowledge that that was achieved, and I think it's something that we should be grateful and proud of all our colleagues who've helped make that happen. And I would be grateful if the board would support that kind of commendation to our staff. We also delivered the money, and we have throughout the year improved the quality of what we do. Why do I frame the debate in that way? Because for a first go in part one today, we will have a little reflection on how do we maintain the tension between the performance, the quality and safety of what we do, and the financial challenge we now face. I think the simplest way of putting the financial challenge is that we're virtually about, I think the last figure I saw was about 0.2% of an uplift for this year coming. So in real terms, that is flat cash. And we know that in that context, demand is going to continue to rise because of the excellence of the analysis in our strategy. So we are going to start grappling today with what does that mean? I would ask colleagues to be respectful of the fact that there are some things that we can discuss in public and some things that we can't, and just bear with us if we defer some of those debates. We will highlight today in particular some of the challenges for the planning guidance. For us, as an ambulance sector, we are asked to maintain our C2 mean across the whole of this coming year, as well as hit our financial duties, as well as continue to improve the quality and safety of what we do. And we'll explore a little bit about what that planning guidance means for other parts of the NHS in due course. So just to add to what David said, probably the most, I can't claim to have 50 years in the NHS, but I think when we combine our collective years, we would both say that this is probably the most challenging financial round that we've ever seen. May the 2nd is the key submission date for people to hold in mind, which is why David was referring to the need to potentially hold a further board meeting it may be a little bit floating because these planning rounds do have a habit of running on. I'd like to add my welcome to colleagues around this table. It's great to have Sarah join us. It's great to have Stephen and Simon also in as part of the team. I'd also note that Lara Whale has joined us as the new Deputy Director of Operations. Further to note just that we are now out actively to recruitment for the Director of Nursing and Quality post, and very shortly we'll commence recruitment for our Chief Paramedic. I'm not going to talk in detail here about the development of this trust strategy. That is an agenda item. The point that I wanted to draw out, I think, is it is an impressive achievement in a number of respects, but I think I would commend it to colleagues, particularly in respect of the wide-ranging and in-depth engagement, both internally and externally. I think we can all be confident that whatever the issues we may have in implementing the strategy, and in the context of the financial backdrop that I just talked about, there will be some, we can be confident that this strategy commands support. And that's really important for any organisation at board level to be able to say. And that was probably all I'm going to say on that. I was, on a more positive note, delighted to see, and I would commend all colleagues around the table to get involved in this, our first Stars of the Month, which is part of our new reward and recognition platform. Putting it fairly sort of colloquially, people loved it and have loved the opportunity to be recognised, but also to recognise other people. I met, indeed, the dispatcher mentioned in the report yesterday, Jess, and I think I just wanted to say, you know, it was a privilege to meet her and to hear her story. Worked in BA as cabin crew for 10 years, then decided to change her life and work in healthcare. Started out by putting herself through education, and now we are supporting her to do her degree while she works as a dispatcher in one of our control rooms. And she had nothing but good things to say about the experience of working in CCAM and how it had helped her change her life and fulfill her life's ambitions. And it was great that that scheme is both up and running, but it brought me and others into contact with people like her who are doing so much for the organisation. Also continuing to recognise excellence, I was lucky enough to go along to our Celebrating Success, which is probably as close as I'll get to ever presenting a proper degree, and to celebrate all the people who have gained various different qualifications. I'm very grateful to the principal of Crawley College, Sally Challis Manning, and the principal lecturer in paramedic apprenticeships, that's a mouthful, isn't it, Matt Bridgman, who came along to the event and supported it. It was particularly noteworthy, I think, because all of our graduates, I suppose I can call them, brought along members of their family, and it was truly fantastic, heartwarming to see the achievement for all of them, both the people, because we forget sometimes the people who've got the qualifications have been at least as well supported, and the journey that they've gone through has been at least as onerous for the people who've had to support them. So it was good to be able to recognise them too. I'd like to thank commissioners for supporting the Heart Uplift in the times in which we live. That is a commitment that we now need to honour in terms of delivering upon the improved capability and resource that our teams need to deliver, and remind people it's the two teams of 6, 24/7, 365 days a year. That is our target. That's what we need to aim for, and I'm grateful to the Audit Committee for increasing its level of oversight of that committee, because increasingly this has become a specialist area of subject knowledge. I will leave the staff survey results for the discussion. I am grateful and thanks everybody for their contribution to those. I think I would, as with the entire team, recognise, as is highlighted both in the well-led review as well as in these results, there is more to do. And the work that we will be doing over the next 6 weeks, so by the time we turn around the June board, my plan is that we will have landed a contract, so we'll have the sense of money, and we will have the plan about what we're going to do in respect of further work on developing the culture in the year ahead for that meeting. We talked, and it has been a consistent theme for the NHS, about the national culture of sexual safety, ranging from right from when people join the service as students through to their lived experience. And this is an issue that I think has become rightfully prominent in the minds of not just in the ambulance sector, but also more generally across the NHS. We are, I think, needing to do more on that, I'm bringing forward a programme of work to include meeting with undergraduate students this summer to hear from them directly about their experiences. Nobody can take this for granted. Nobody nobody could say this is not an extraordinarily difficult area to face into, but face into it we must, and we need to hear directly from everybody who feels that they are affected. But in particular, we need to pay attention to some of our communities who represent the organisation who are vulnerable, which is why that focus on students is so important. I think that's probably all I am going to highlight today. And again, want to end with the note of, as my report does, with the positive operational performance. It's nice that we haven't actually had to spend too much time debating it. And I would just contrast that with some of the other challenges that have been faced by both colleagues in the sector. And I would just end on this note of we need to not take it for granted that that is going to continue to happen. We've been really fortunate not to have to focus on it as much as some other services over the last year. And so on that slightly equivocal note, I will pause and happy to take any questions.
But at the same time, let's celebrate what we have achieved as well. So thank you. That's a very comprehensive report, Simon, and there's a lot in it. Colleagues, questions of the Chief Executive? Any challenge to what you said? You're comfortable with his summary? Okay. Those who are watching this meeting will think we're giving you an easy ride, Simon. But I hope the silence means approval.
Sure.
And you know, Michael's going to save the day. Michael, challenge, question.
It's very positive. I think we do need to reflect and to give our support to the Chief Executive, because the position that we face ourselves with now, while it is challenging nationally, is significantly different than where we were a year ago. So I think it is important as a board we acknowledge the progress that has been made. And I look around the room, you know, we've almost effectively got a new executive team. All of this has been done at incredible speed, in my view. We have the basis of a really good strategy that the commissioners buy into. None of this is simple. We need the money to deliver. We know that. But I do think we are in a stronger place. I would just say, you know, as an auditor by background, I always have to be cynical, and I would support what Simon says. We can't be complacent by any means, and the next 6 months are going to be very difficult. So it's not challenge David, but it's really to endorse your support.
But I think one of the papers you'll see later is a detailed report from the chair of the Finance Committee. And at the last meeting of the Finance Committee, obviously we went into some detail into targets. And whilst the headline target is category 2, which is, this is life-saving stuff. This is heart attack and strokes. With a 30-minute response time is still not up to the standard we'd all want for ourselves and our patients overall, but nevertheless, compared to the rest of the country, we're doing outstandingly well, and I think we need to acknowledge that. However, there's other targets in there where there's been some real improvements, and again, those who are the official historians of this board and been around for a while will know areas like category 3, category 4, our hear and treat rate have been a cause of some concern. Our response times to the telephone calls, but all of that was showing some pleasing improvements, which is running parallel with some cultural improvements as well in our AOCs. So all these things are joined up. It's all captured in our reports. But it was really good to see that, which the Finance Committee picked up with some gusto to see that general improvements. And I say the Chairman of the Finance Committee, Howard, will refer to that in due course. But that just it's brought together nicely. The money and the quality do come together, and they do one. You can't have one without the other. So well done, Simon, and to the team, and more importantly to those that support you as well. We have to recognise that we run the place 24/7. There's a lot of managers out there, leaders leading their teams, our UM colleagues, those who lead the corporate departments have worked very hard for the cause in the last 12 months. And I think we just need to acknowledge that as a board. So thank you for that. Right, let's move on then to our sustainability and partnership section. And to set the scene, we're going to take the board story, and Margaret is going to introduce this. Margaret.
Thank you, Chair. So we're moving into the section now where we're going to be focusing on the strategy. And I'm delighted to be bringing the board story to you, presenting it to you, in that this is proof that the patient is at the heart of what we do. And it's really important, all of us that work in these kind of sectors, to do that. In development of the strategy, we did indeed consult the public. And moving forward, that's going to become more and more important to hear how patients and the public expect to see things happen and want to see things happen, and then their experience of it. We've got more to do, but we have achieved so much over the last 12 months, seen through the patient engagement strategy and all the improvements that have taken place in all those areas that the public do access us and provide us feedback, whether that's good or bad feedback. The short film we're about to show you illustrates some of the ways we do hear from and we do engage with patients, and I think you'll be surprised at the kind of volumes that we go through. And this also highlights to us the opportunities we have to carry on tapping into that and also to increase it in things like the community forums that we started this year. We've now held 4 community forums across all of our sector systems, which have been enlightening and quite engaging. The format of the film is a new approach for us, and so I look at Janine there, and we thank Liz Spires for really focusing on this. So enjoy it, and we would welcome some feedback on the format as well. Thank you.
Here at CCAM, we serve a diverse population. From planets of Farnborough, a staggering 4.75 million people across 3,500 square miles. As a provider of 999 and 111 services, we responded to 2.2 million calls last year. That equates to a call every second. Hearing from our patients about their experience of our services is really important to us, and we're working really hard to improve how we do this. We've introduced new feedback cards on every ambulance, which allow patients to provide instant feedback on the care they've received, or later on, if more appropriate, via a QR code. Surveying our 111 patients by text already helps us to refine and improve the care we provide. During 2023, more than 100 surveys per week were completed, with callers sharing their feedback on the service they received from 111. We're equally happy to take any feedback via letters, cards and calls. And last year we received more than double the number of compliments than complaints, with 1,700 compliments compared to 760 complaints. That's 1 complaint per 2,895 calls we received. Learning from feedback is really important to us. The top 3 reasons why people raised a concern were attitude, NHS pathways that need changing, and timeliness of response. All of these are helping us improve the care we provide. Hearing from our patients directly via our community forums is also proving invaluable in understanding the issues that are important to them. Launched in December 2023, the forums are held virtually every other month and provide opportunities for them to share their experiences and learn more on what we're doing to improve the care we provide. The forum is just one of the avenues we've used to engage the public and patients on our new trust strategy. Making sure we listen to the views of our patients and local communities through the development process. Alongside our staff and partners, we were delighted that 350 people provided feedback, which is actively helping to shape the services we provide in the future. But we've not stopped there, as we're also providing more feedback on the care we provide to those who deliver it. Thanks to the hard work of our 111 patient experience team, we're now sharing patient survey feedback with call takers and recognising those who received repeated praise from patients they had assisted. Our 999 clinicians are now being informed about the outcomes of cardiac arrest patients they've treated, and if they have survived 30 days post-cardiac arrest. This is helping them to close the loop and reflect on the care they gave. These are just a number of ways we are listening and engaging with our patients, their families and our communities. And as we finalise and implement our new trust strategy, we are committed to ensuring that the patient's voice remains at the heart of everything we do.
Thank you for that. Most informative. Liz, you're chair of the Quality Committee, but you've also championed this cause since you joined the board. Any comments you wanted to make?
I think just to say this is a very small but perfectly formed team that have made these huge improvements over months rather than years. And I think the PALS teams who sit with our 111, our patient experience teams, are so motivated and enthusiastic about actually talking, meeting with our public, but also our complainants. And actually at the patient experience group meetings, we also invite Healthwatch, Kent, Surrey and Sussex, who are very vocal about our local communities. But I think the work, getting the feedback, then acting on the feedback and making a difference to our communities out there is a real success for us. And, you know, my thanks to the team, who, as I say, it's a few individuals that have made an absolute difference to our patient experience.
Thank you. Colleagues, any other comments? Michael?
Yeah, really impressive, and thank you. I really like the new format. It's incredibly difficult. One question I've got is, are you confident that the feedback we're getting represents the full population makeup? Yeah, you know, in terms of diversity, because some people are more prepared to speak than others. And I know this is difficult, but could you comment on that, please?
No, I can't say we're confident. So you saw that we've had over 300 responses with a £4.something million footprint. One of our areas for growth this year is to really look to see how we link in with the hard-to-reach groups. So we already have identified across the three systems different forums of different types of diverse groups, and we're engaging with them to see how we can link and how we can start getting feedback. We know that not all will want to join forums, not all will want to have face-to-face or even virtual meetings, so it's just getting through. We have now just recruited an administrator to help our patient engagement lead, and that will help us hugely in starting to make those networks. So I think that's a great challenge and the one that we want to take on this year.
Thank you.
My sense is as well with the strategy that we're pursuing, or the management, the leadership arrangements Simon's developing regarding empowering the local unit managers, they do have very good contacts in what we could refer to as place in local communities. So are we going to be partnering with our local leaders to ensure we really do understand the populations we serve?
Yep, so we have this as a standing item now within our system-based quality governance groups, and again, over the course of the year, we'll be increasing the discussions that take place there. And as we establish quality leads, they, with their local leadership teams, will be definitely pulling the muscles, because you're right, there are people that are already well connected and certainly have knowledge of where to go to. It'll just be a slow move this year because there's so much going on. So I think our ambitions need to be realistic, but we definitely have got ambitions to go that route.
And the other question I just wanted to ask was, I was really pleased to see they were feeding back to our staff the outcome of cardiac arrest responses. How are we actually doing that? We actually got contact now with the hospitals, and are we getting feedback regarding these cases so our staff can really, because I think that from a point of view of given us, the challenges of those episodes, that must be a real boost to our staff to have to get that direct feedback.
Yeah, so we are reliant on hospitals and sharing information between hospitals, but we do also hold a significant amount of information within our own systems around success rates of resuscitation, but we're limited at the moment in what feedback we provide with staff. This ties in nicely with our supervision agenda, which, as you know, we're rolling out over the next 12 months, and providing that level of supervision with senior clinicians will also aid that feedback loop. So very positive.
Margaret?
And just to add, Chair, that we're having a discussion at the ICS Quality Collaborative next week, actually. We're trying to set up some sort of understanding through the information governance route, whereby through PISA, we do need to start accessing the outcome of patients. It makes no sense not to have it because we're only a small part of a journey. And we, at some stage, will need to look at before as well as a system. But for now, for our own staff, if that's the only driver, that's a strong enough driver, we do need to know what the journey was like for all cases, not just our cardiac arrest. So we are working, and again, the system groups, quality governance groups, will have the local patient safety leads connected to them. So again, building up the relationships, building up that, and sorting out the information governance. So Peter and I are on that with Caroline.
Yeah. Any other questions, comments on this?
Yeah, I just wondered how do we measure we're being successful in all these? It's great, that was wonderful, but I just wondered how do we measure success?
That's a challenging one, Paul. Thank you very much for that one. I think it will be, first of all, data-wise, there'll be increase in numbers, so we can show more and more people are joining, engaging. For each of the new initiatives we put in or that we continue to develop, we are alongside it doing evaluation tools. So one of the things we're learning through the QI is we really shouldn't start anything without having worked out how we're going to evaluate it. And part of that is then how do we know it's got any meaning, that it brings value, and that, I guess that's how we know it's getting better. So I think from what we already have, we know it's better than it was 12 months ago, and we know it's better than it was 12 months before that. I guess we need to start putting some realistic but ambitious measures in there, and so each of the steps we take are having evaluation measures put in. So it'll be through that.
Let's look at some other sectors. There might well be some other consumer-based organisations that do a lot of do a lot of work through telecommunications that we could learn from in this area. So I think there's some good examples out there. Particularly the mobile phone companies and others, I think, have done some reasonable work in this area. Right, colleagues, any other points before we move on? Thank you for that. Just to then move on to the really important part of today's meeting is the trust strategy. So, Simon, are you introducing this, or is it then over to David?
I'm introducing it, and I'd like to welcome Andy and Matt to our board table, who will be helping take us through some of the highlights. As I said, I think we can be confident in what we are presenting here today because it has been the subject of such wide and continuing engagement. And on the points that were just being made about engagement, clearly we've got two sources of information. Not only have we got our own inputs, we've also got the fact that we've been talking to the ICBs so extensively over the last 6 months, and they have their own sources of data and network. So with their own population, so we can hear that in the conversations that we've got too. I think the key message from me about the strategy is that we have to find a way, the key question that we have to satisfy ourselves on is, can we find a way to continue to protect, preserve and defend the core patient offer, which is when you really need an ambulance, we will be there for you. When you are really sick, we will be there. And not only will we be there, but hopefully over the next few years we'll be there even quicker than we are now. Because we shouldn't just accept that 30 minutes is the kind of gold standard. We know it's not. So that's the first paradigm. And the second is, can we share with you, can we work with you as patients to make sure that if you don't need an ambulance, we can help you get somewhere that will meet your healthcare needs. And at the heart of whether we can go with this strategy are those two questions in my mind. I said, and I've said repeatedly, I've been slightly haunted by one stat throughout this whole development. Since 2018, it takes us 40% longer to get to you if you've had a stroke. And for me, that's something we've got to reverse over the next 4 or 5 years and is at the heart of our strategy. I'm confident that with this road we can. It's not going to be easy. It's going to have some real challenges. But I think this does that most important thing for all of our staff. It offers them hope that there is a future. And with that, I'll hand over to the team.
Thank you, Simon. I just wanted to take us back to 27th of April 2023, when for the first time as a board we got together with the Council of Governors and we set out we need a new strategy to take us forward because our previous strategy was coming to an end. And I've pulled up some of the things that we talked about. We talked about why do we need a new strategy, how do we want to engage with the public, partners, patients, and what are the key challenges we had to address. And what came across very clearly at that point was this had to be a clinically led strategy that put the needs of our patients at the heart of it in a way that was supportive of our people and recognizing the fact that we don't operate in a bubble. We operate as part of an integrated care system. And in our case, systems, because we operate across 4 of them. So the challenge was set, and some of the things that we captured. This is real from the post-its that we collected on the day. We need a strategy so we can provide the highest quality of patient care and the best outcomes, so we can anticipate changes before they overtake us. We wanted our staff to feel listened to, and we wanted to have some meaningful engagement with our partners so that they could see their voices and their needs reflected in the final product. And we said we wanted to be grounded in reality, but we wanted it to be ambitious, bold. We wanted it to feel risky. We wanted to have something that really set the difference as we look over the next 5 years. And we wanted something that was a roadmap not only to deliver that quality patient care, but also to make sure that as an organization we achieve sustainability. We're not in this position where we're constantly trying to achieve a financial number at the potential detriment of patient care, and how we resolve that equation. So what the board has in front of them today and what the exec team are putting in front of the board for endorsement and recommendation is the strategy, the product of the work that we've been doing over the course of 23-24. And just to talk about engagement and how we answered some of those challenges, well over 2,000 colleagues have provided us with feedback and have had input and have been part of the conversation. And I would like to thank publicly, no strategy team can do this by itself. I want to thank all colleagues across the organization. We've had some fantastic support from local teams who have nominated local engagement leads. I have personally been invited to multiple pizza nights where the strategy has been discussed and input has been given, and that's where really we've been able to drive the momentum. And as we close the delivery of the strategy chapter, one of the things as we think about how we open the transformation chapter is how do we continue that engagement? How do we continue to listen to our people, to our patients, to our partners as we implement the change? Because that's going to be one of the key success factors as we move into the next phase. But at this point, a big thank you to all of our people who have helped us engage meaningfully. Also a big thank you to our system partners who have been steadfast in their support to help us get to some of the right answers and to help us keep up with the pace that we had set, because we knew we had to get to this board in particular with the new financial year and with a clear roadmap ahead, something that helped us shape the strategy of the organisation over the next 5 years, and starting with what our objectives are going to be in 24-25, which is, as Peter has said, something we will bring forward at the next at the next board in June. So at this point I want to hand over to Matt and Andy, who I think will take us through a couple of slides just to highlight what our case for change was, what is our proposed target service model, which is at the core of what we've developed in the strategy, and we'll then take a round of questions. So over to you, Steve.
Thank you, David. So we've just got 2 or 3 slides recognising that the board has had the strategy pack that has a comprehensive update around where we've been and where we've got to. The slide on the screen here is our initial case for change. I'm not going to go through it by each component, but just using it as a bit of a point of reference. So looking back, what did we identify from our case for change? We identified that demand is projected to increase by 15% over the next 5 years. That's due to healthcare becoming more complex. That's due to the population ageing and areas of deprivation within our footprint changing fairly considerably. Within the case for change, we've also identified that our current model of care, but also the models of care that we operate within across our 4 integrated systems, are unsustainable and challenged from an operational, workforce and financial perspective. So what our strategy suggests is that we need to look at how we ensure we deliver services, to Simon's points, that are aligned to patient need. So the model is very much focused, and Andy will take us through this shortly, around a differentiated care approach. So how do we ensure we get the right, timely, immediate, physical, standardised emergency response for those high acuity, critically unwell and injured patients? And how do we ensure that we personalise and tailor an approach locally at perhaps place level, to David's point, for our non-emergency and less urgent patients? We've suggested within the strategy that this focuses on 2 key enablers. One is the use of advanced technology. So how do we introduce the likes of artificial intelligence to optimise our triage and dispatch processes? How do we look at introducing virtual response and virtual consultation across the organisation to support that virtual response component of the strategy? And how do we best equip and support our people, including our volunteer colleagues, to ensure that actually their skill sets, their capabilities and development aligns to patient need, and we best support our people across the organisation? So what do we need to change? Well, one of the key stats that colleagues may recall came out from the case for change was that currently we respond with a physical emergency ambulance to 90% of our incidents. And we know that actually, when we look at clinical outcome, only around about 13.5% of those patients actually required that physical response. By 2029, we are looking at directing via signposting and referrals 35 to 40% of patients to a more appropriate pathway of care, optimising the use of that virtual response component. And again, this will require investment and a focus organisationally and working with our system partners on both the digital component and how we best support and equip our workforce. I think just to give some assurance to the board, we're aware that the NHS operational planning guidance for 24-25 was issued in the last week. We are very much aligned to that. So our strategy does prioritise effective response requirements as outlined within the guidance for the next financial year, how we improve and enhance staff experience, focusing on both retention and the well-being of our people, how we ensure patient safety throughout the core components of our model, and how we work with systems to ensure productivity across the region that we serve. As I said, I'm going to hand over to Annie now, who's going to talk us through the service delivery model, and then happy to take any questions.
Thanks, Matt. So just building on on what Matt was saying, so to the left of this slide, you're seeing really what is the de facto operating model for emergency medical services probably throughout the world, where it relies on first contact with a telephone call, an algorithmic triage system, which is highly effective. And we mustn't forget that our first contact is with our emergency medical advisors to all of our callers, and that triage is effective. Where we have an opportunity, and that, to echo Matt's point, is in what we do next. So moving from a predominantly physical response, which leads to fairly low levels of need for the ambulance as a vehicle to move a patient to somewhere else from where they are. If we're going to live through a global pandemic, one of the things we are required to do is learn from it. And if we look at other sectors who have successfully pivoted to a far more remote model of care, so primary care, outpatients departments, and a range of referral options are now mediated through a first professional contact in a remote setting. So we're moving from that, what we've kind of termed a speculative model, where we are sending an ambulance to see if the patient needs an ambulance, to trusting the triage, which is it's most effective at the apex of our patient group. So our sickest patients are served very well by our triage system. And patients who triage in lower categories, it's less clear. So it's the specificity versus sensitivity of our triage systems. So what we're pivoting towards, and you'll see in the graphic on the right, is still relying on that high quality effective triage, but only based on good validated data, and that has emerged a lot recently. We've done some tabletop exercises to reassure us that patients that need an immediate physical response are getting or will get an immediate physical response. And those patients with presentations who are safe to receive their first clinical contact virtually can do so. So it splits that cohort into exactly what Simon has suggested that we need to do, which is to achieve high response time reliability for our patients who have new acute onset diseases and for whom the treatment window is time limited. And at the very apex is reversible cardiac arrest, where we have seconds to act, all the way through diseases such as stroke, heart attack, major trauma, childbirth and newborn care. Now, it's important to say that patients who receive a virtual response as their initial professional contact, that doesn't mean to say they will be resolved solely over the telephone. So the word differentiate comes up a lot, and what we mean by that is we will seek to understand the patient's ideas, concerns, expectations, and to differentiate their clinical need and align that need with the system at the time of day. So healthcare changes during in-hours, during the weekday, it changes in the twilight period, it changes is overnight, and it changes over weekends and bank holidays. So as a partner, we are required to align patient flow and cut the ties, or cut that default position where we will send the ambulance and take the patient to ED regardless of the time of day. So we have opportunities to, as an example, to utilise same-day emergency care in much greater numbers, where we take our patients who present in the evenings and overnight, risk stratify and risk manage them, to Michael's point around how we manage risk relative to the risks we see now with patients accumulating in our stacks, and through the consent of the patient, take them to the right place at the right time with the right resource. So sparing our paramedics, whose role is to attend patients to make complex decisions and to provide interventions and care in transit, and giving our non-paramedic workforce, who are fantastic at providing care for patients for whom the decision is already made for their care. So, and that can include interfacility transfers and healthcare professional admissions. And then the last bit really is there will still be a lot of patients for whom the influence of advanced practice, and that is the basis of our remote consultation workforce. So 2/3 will be our advanced paramedic practitioners, and around 1/3 will be our paramedics who are supervised by them. Some patients can be given definitive care or definitive signposting over the telephone. So hear and treat will increase safely as well, to complement the already amazing work that's done in our Category 5 intrinsic hear and treat that we already see. I think that's covered the graphic.
So I think in summary to colleagues of the board, we have identified a strong case for change through this process. And we're pleased to present a co-designed strategy that's been designed very much with our partners, our people and our patients and communities, that will allow us to cope with the demand and complexity of the patients that we'll be serving and facing over the next 5 years, allows us and enables us to play a core integrated part within our 4 integrated care systems to ensure we have an empowered and supported clinical and non-clinical workforce, and that we operate in a sustainable and financially viable way. Just on the right-hand side there's some key system enablers. I think there are some key success factors that we've also identified that we would recommend to colleagues of the board, and there's 3 that I'd just like to talk to this morning. Andy's touched upon we will need to continue with the ongoing strong clinical leadership that we have fostered and enabled both internally and also working with our external system partners. On that, we need to continue with the strong and effective system collaboration that we've continued to nurture and seen some real improvements, as has been referenced in the last 18 months to 2 years of both the improvement journey and the strategy delivery. And thirdly, continued board endorsement, monitoring and support of the strategy. The journey really starts now. So this is the strategy document, but we now commence and embark on the next 5-year period as we move through those 3 phases. So that's it from the strategy team. Thank you.
David, any further comments?
Very little to add. I think the team have done it justice in terms of the work that we've done. You've got the pack in front of you, and we look forward in terms of next steps. Obviously, subject to the board's endorsement today, we'll be looking to publish a very nice looking. We have some exciting branding design work that we're doing to complement this piece of work, and we'll be looking forward to publish it in a very easy to read with some very clear outcomes for the public and some really clear messaging on our website in May. So that's the next steps. But over to colleagues to ask any questions of us.
Thank you. Well, first of all, thank you for the explanation. Thank you for the way it was presented. Really excellent summary. Thank you. And it really brings over the importance of the work, and also what you said at the start, it's grounded in clinical reality. That's just so important from the point of view of actually both the organisation but also the people we serve. So colleagues, the board, you have before you the strategy, you're asked to endorse it, but also it's your final chance to make any pre-flight checks, as it were, because once it's signed off today, this is it. And this is going to set the direction of this organisation for the coming years. So it's really important that we're all engaged in this, that everyone owns it, and more importantly, it's going to behave in the way this strategy is dictating. So I think it's important. So colleagues, Richard, you were first with your hand up.
Thank you, Chair. I was just going to reiterate a point that's been made several times around clinical engagement and clinical leadership, and I think that's key to the success of this strategy. And I just wanted to pay tribute to Andy and the team working in partnership with Matt and the strategy colleagues. We put a consultant paramedic in charge of the clinical engagement deliberately, and I think it's paid off, and our clinicians support the final version. And that is a really powerful message, that our clinicians on the ground support what we're proposing here.
Thank you for that. Well much appreciated. Other comments? Paul?
Yeah, I just wanted to see how what position we're in terms to mobilise the strategy. The strategy is brilliant. It's really exciting. So it's wonderful. I just wondered, how do we know we're in a good position to start it? How can we mobilise it effectively? Are there any big building blocks missing? How do we stand?
So I'll to start.
Yeah, I mean, I think that's the subject of the next discussion, Paul, rather than because clearly our ability to implement the strategy now depends on the outcome of the planning round discussions that we're in. So I would suggest hold that thought, and we will be coming back to you in June. What I would say is that in developing this strategy, as I previously said, we're not sitting here today as a product of the strategy team having spent 6 months in a darkened room. Not only have we been out and about internally, we've also been out and about externally. But it's a key question about how we implement the strategy in the context of the financial challenge we face.
Yeah,
thank you. Before bringing in Michael, just remind colleagues, a member of this board used to use the saying, operational problems have strategic solutions. And also, in terms of the discussions we are about to have, or are having and will have with our partners, it's important that we have a sense of belonging, a sense of belief, and we have a clear thought process in our mind, which is clinically validated. So I think this is why this gives me great heart, this programme, quite frankly, in terms of the fact it's come from the heart of our organisation, our clinical expertise, but in partnership with the public and others who know what we can do and what we want to do. I think that's really important that we have a sense of confidence about this going forward. Yes, we might have to tack in the wind a little bit, and there may be some financial constraints, but I think it's important we have belief, quite frankly, and because you are the experts. The board is a collective expertise, but the expertise in our clinicians, and we have to believe that.
I think Max and Howard, and then I'll come
Yep,
to
sorry.
the microphone.
Max, Howard, then Michael.
Yeah, thanks very much, Chair, and thank you very much to the team. The word you just used, confidence, I think that's what this strategy gives me. I think the breadth of the engagement, I think the depth and rigour of the data analysis. I mean, throughout the process, I've been very impressed by particularly the sort of the insights that you've drawn from really comprehensive data analysis. I think we as a board can take much confidence from this document and the great work that underpins it. And I think what's particularly great to see in this particular paper is that we start to see some of the outcomes. So how will we know, what will we feel is different as we deliver against these outcomes in terms of quite easily measurable pieces like call answering times and response times, through to more of the intangible that we've really got to go looking for indicators of success. So I'm hugely supportive and endorse this.
For your contribution as well, Max, in terms of the initial work for this as well, has been appreciated. Howard?
Yes, thank you. A great process and a great result. I have, so well done. I have one question. Obviously, one of the implications of the strategy, and I know you've engaged extensively externally as well as internally, but I was just wanted to question about the fact is that we're referring to other services up to, I think, 30% or something, much more than we were before. And the question is, are those services aware of that and prepared for it?
Yeah. So we have engaged extensively. I think at the moment, then some of the pilots that we've done in East Kent in particular show that the capacity is not there at the moment. One of my key messages that I say here and I say everywhere is we can't do this by ourselves. And this strategy is a real test of integrated care and joining up care at a multi-system level, because this requires a singular vision and approach for what our role is. And this strategy sets out there is a more appropriate way to respond to patient care need. And we have put that case forward, and that case has been accepted. So part of the discussions we're having with commissioners at the moment is, well, what does that multi-year journey look like? And that's, I think, part of the detailed discussion we need to have in the private session, Howard. But I think there is going to have to be a piece of end-to-end capacity models of care design that we will be proposing as part of the detailed transformation program that looks at what does that some of that major pathway redesign need to look like as our role shifts. The role of others will also need to shift. But what we should remember here is we operate as a system. So overall, what we should be concerned with is, are we doing this in a way that supports best patient care in the first contact? Because remember, the ambulance service may move people from A to B, but then we're not addressing the core concern and the core cause for which people were calling us in the first place. And that's part of the issue that we have been seeing. But also, sending a fully kitted ambulance is a very expensive way for the public purse to respond to some of that patient need as well, whilst others may be able to address that patient care need in a more cost-effective way. And that's where the system thinking needs to come in. Hope that helps.
Emma, just make a supplementary point before I bring in Michael.
Yes, thank you, Chair. I think we need to also recognise we're not starting from scratch. We are very clearly, the last year has had some real improvements in these kinds of pathways, whether you look at the East Kent model, or I will bring to the attention, which I know the board are aware of, the work we're doing in EOC, where we have now got community services using a web portal to pull calls off our stack where they're appropriate for urgent care teams. So I think we have already moved some way along that journey. The scoping is most important, because we also recognise the ICBs are in different places and they've prioritised different pieces of work. So now it's about how we intersect with that. But we have We have come quite a long way, even in the last 12 months. And I think that's helped all of us, ourselves as a provider and our partner providers and the commissioners, to really understand what is in the art of the possible and where there are gaps, because actually there are going to be gaps and we will continue finding them. And it's finding solutions that work. And that'll look different at 3 o'clock on a Sunday morning than it looks at 3 o'clock on a Tuesday afternoon.
I mean, that's why the confidence is important based on reality. I mean, if I think back 15, 16 years ago, it was the London Ambulance Service that set the pace around heart attack, stroke and pathways, and the hospitals and others followed. So I think there's importance about what's our appropriate professional expertise here that's used responsibly. Michael, and I'll bring you in, Andy.
So I'll be very quick. 100% support and thank you to everybody for what's been done. I don't want to get into implementation. The one thing I'd say, and it didn't strike me as strongly as I'd like to see in the success factor. So you've, pardon the Duke of York adjective, we've marched everybody to the top of the hill, right? Everybody's really positive, they feel engaged. The real risk now is, are they going to see a difference? And one of the key success factors for me, and I really as a board member want to hear, is that the people in the organisation, 6 months, 2 years, whenever it is, begin to see a difference and are actually advocates for that difference that it's achieved. Because we all know, you know, it's easy to develop a strategy. You've done it brilliantly. But if they don't see a difference, we will lose them very, very quickly. That's my first point. And my second point, it is in the implementation phase, and I don't want to go into detail now. I hear so many organisations across the public sector say that AI is the solution. It will drive productivity. It will do this. When you prod a little bit, and I'm fortunate I can do that as a non-executive, what does that really mean? Okay, you've given examples, but I would just advocate that as a board, we need to spend quite a bit of time over the next 12 months to 18 months as to really get to the nub of what is we can achieve, particularly because I think we've got a public that are increasingly sceptical in this space. And I'd also say that the GPs moving to online appointments has not gone down 100% well. So I just think that it's great, there are opportunities, but we need to spend time really getting to depths with that. I'm sure you have that plan, but I just want to put it as a marker out there. Thank you.
So if I deal with both of those. So on your second point, yes, you're completely right, Michael. I couldn't sit here right now and tell you what AI capabilities the board's going to invest in. But that's why we're investing in a CDIO, because rather than waiting for this agenda to wash over us and respond to it, we need to invest in the thought leadership to actually to lead that debate and work out how we do take advantages of those opportunities. And that's not been a capability that we've had around this board table before. And so we have recognised your challenge in the fact that we are creating the CDIO role and need it as heart of our debate in terms of implementation. And I'd make that point more broadly by saying there will be other capabilities that we need to develop around this board table that we do not yet have that will help us successfully implement the strategy. On your first point, I would say we sat around this board table a couple of months ago and we heard from the Ashford team about how taking control over what was a problem and turning it into an opportunity made them feel very differently about it. At the heart of our year one implementation plan is the rollout of those hubs across our estate. We will have a very tangible measure to know whether we have been successful or not. That will both benefit the local systems, but also, if we're correct in the assumption, which we think we are, will also benefit our staff and the way that they feel about the work that they do. I was very powerfully struck, as I know we all were, not just by the performance metrics that the Ashford team presented, but by the way staff felt about having more control over what they were doing. Scaling it up is now the challenge, and I can feel the auditor's scepticism moving across the table at me, but that I think we can be confident that we've got the right idea. what I think we now need to do is to demonstrate the fact that we can and will scale it up.
Thank you. Andy.
I just wanted to respond to Howard's point around the shift in demand. So the perception that we'll create more patients with more illnesses is a really common challenge. So it's going to be the same number of patients with the same conditions. What we do differently with them will help shape flow and demand. So a good example of a partnership benefit. So patients who wait longer for an ambulance to come may deteriorate. So delaying their definitive treatment may create more bed days, may reduce rehab potential. So that's a way of, if we can do better upstream or flow the patient into the right place, we will shift the demand to look different and to have less of an impact or less of a negative impact compared to where we are now in terms of quality of care and partnership working.
Thank you. Sue?
Thank you, Chair. Thank you for this. This is really, really exciting. I don't know if anybody said that, but it is really exciting. And we've been on at you, I think, for the longest possible time about having a clinically led strategy, and that is exactly what we have got. So, I'm absolutely delighted and very happy to endorse it. You touched, David, a little bit around working with the public and that you were going to, put some messages out and things like that. And of course, this is different to how we work. They are going to feel a slightly different service. So how can we reassure the public around the fact that, if they dial 999, they're going to get a good service. If they call 111, they're going to get a good service. It's important to say we did road test the workforce plan at People Committee as well. Some really good work came to People Committee on the detail of the workforce plan and how that was going to look. And it's a real testament to the success of the clinical education team as well, that actually we were able to see how that talent pipeline was going to come through. But my question is around the public. How do we prepare them and socialise this with them so they know they'll still get a good service?
So I think, and I'll let Margaret come in at some point on this response as well, but I think ongoing patient engagement as we roll out the changes is going to be essential. We can't do this by ourselves. It means we can't do it with our partners, we can't do it with our people, we can't do it with our patients and the communities that we serve along the way. So I think that's going to be our strongest ally as we measure success. We've seen in the board story some examples of what the team are doing together. It's great to hear that the team is increasing in capacity, because I think the more and more we change, the more and more we'll have to have our ear to the ground and listen to patients and actively engage with them so we can understand outcomes. The outcomes piece is also really important. So how we integrate data, understanding full system outcome. So looking both at the micro data and the individual patient feedback as we develop changes and we do things differently, as well as what is the macro outcome data. That is something that I'm really excited to see, so we can really prove that this is having an overall outcomes. At the moment, we only measure the process and the time it gets to stop a clock. And I think what you've heard from Andy as well is this is a strategy that should benefit the outcomes at a system-wide level in a number of different ways. So 2 layers of how I think we need to listen to the patients. And I think that's the strongest tool that we have to make sure we're bringing the public along the journey with us.
Thank you. Janine?
Yes, I was just going to say, I think what we have seen through the engagement we've done on this is a recognition from the public that actually our service model isn't meeting all of their needs at the moment already. So while there is a perception that and a reality that we are there to help them and will always help them, their reality of an experience of long waits for lower categories of call is already there. I think what we have heard from them is they want us to do something differently as well. So I think it's absolutely about reinforcing the our commitment to being there for them when they need us, be that when they're very sick and they need that very speedy, very quick, complex response, but also to help them navigate through when it's not in that scenario, which is probably the strategies identified where we're not getting that right at the moment, which is impacting on our patients. So I don't think there is, we heard through the engagement we did, that overwhelming perception that we are already meeting all of their needs as they would like at the moment. So absolutely that reassurance is really important, but I think it will be, as with our staff, it will be the impact of them seeing something different and navigating through that in a better way than now.
Thank you. Margaret?
And just to build on that, if I can take you back to the film at the beginning, the board story. So the top 3 reasons that have been that for the last 2 to 5 years is the attitude, the timeliness and the interventions. The strategy addresses all of those. So we now, having done a deep dive in attitudes, which is coming to People Committee next time, we know the 2 overwhelming themes are the attitude towards care staff, healthcare professionals. I say that with a bit of hesitation because we know in the care homes they're not professionals as such, they're carers. And also, so a feeling of staff that they're being sent to the wrong thing. So therefore the attitude that the patients receive. So we can be pretty confident that if we land this, all those 3 things will be triggered because our staff will feel highly motivated. They will be going to the calls that require the ambulances. They will therefore respond accordingly. People will understand, so the care homes will understand what we're there for, and we will navigate them to the right place if we get different calls. The timeliness of responses is absolutely what the strategy is going to be addressing. And then the interventions, again, we're dealing with that. So I think even just through the normal routes, the majority of the public will never engage in the way we would want, but you know, in co-design and all of that, which of course is another one of our strategies going forward, but they will feel a difference, and from that I think satisfaction, what Janine was saying, satisfaction will increase.
Thank you. But I think go back to my theme about confidence again. Our staff, though, is irrespective of all the challenges we've faced, are held in extremely high regard in their local communities. And we really do need to build on that because they are the ambassadors, the best ambassadors of the NHS, of the people who work in the NHS, providing they're in a positive frame of mind. And that's the opportunity we really have with this strategy, because given the geographic footprint we cover, that's what we do need, that confidence, but based on reality as well, and never complacent. So, colleagues, I think we've had any more questions, comments on this very important item. So I think we can, as a board, accept and endorse the strategy. We do so with extremely warm thanks to those involved in its formulation and to our wider community as well within the organisation. It is an important moment, and that will help set the direction of this organisation over the coming years. And there's clearly more to do, and there's clearly a detailed implementation plan. And as the Chief Executive has indicated, there's going to be some negotiations needed with those that fund us, but I really would encourage the fact that when it comes to out-of-hospital emergency care and telephonic response to patients and triage, you are the experts. Our clinicians are the experts in that field, and we must always remember that. And we must use that expertise carefully in that negotiation, but nobody else can tell us how to do our job. So it's really important that we take that forward in that collaborative light, but also say with confidence. So thank you for that. It's a great piece of work. Let's move on, if we may, to taking the report from the finance report. I think Simon's going to introduce this initially. Simon, as Chief Finance Officer.
Yeah, thank you, Chair. I'll take the report as read. What it says is at month 11, the cash, balance sheet, revenue and capital budgets are as expected. Additionally, we expect to achieve an outturn of break-even in line with plan, although that is achieved non-recurrently this year. So what does that mean? That means if you strip out of that break-even position things like non-recurrent asset sales, non-recurrent cost improvements, as well as the impact of pay awards this year in that flat cash environment that Simon referred to earlier, the organisation starts the year next year with a £16 million deficit, all things being equal. And that's before we invest in workforce, our strategy, and other investments. It is April now, so our year end is underway. So this is the process by which we produce the annual accounts, which will be subject to external audit. That's going in line with our expected submission date of the 24th of April. So quite brief from me, Chair. I think the report is clear, but happy to take any questions.
To the point, celebrate the year ends, but it comes with a cautionary note, and particularly going forward into the new financial year. Simon, is there anything else as Chief Executive wanted to say about where we are currently? So I think, first of all, we just acknowledge the work that has got us to this position in terms of one of the good things that CCAM has achieved is we have has a reputation of financial discipline, and that has continued this year in terms of meeting our financial obligations. You're right, there was some cautionary notes regarding the non-recurrent aspects. So in terms of our planning, just to seek some assurance that, and again, hopefully the Finance Committee as well can give this, Finance Chair can give some assurance, we are beginning to look at, are we at our cost base, to make sure though that in the negotiations going forward we are in a strong position and no one can tell us things we should know already. So we are, I hope we're being challenging, are we, regarding cost improvements, how we run the business, etc. Is that work underway?
It is. You'll see from the next presentation that we've increased our expectations around cost improvement for next year. That said, this year's efforts were not insignificant, and it is a good achievement to set a target that's a high one, and then do the vast majority of it, even if some of it is non-recurrent.
Howard, do you want to introduce your finance report? Chair of Finance Committee.
We've got the operating plan.
Oh, sorry, I do apologise. Operating plan is next. Who's leading off on that?
Simon again.
Simon.
Thank you. So the presentation in the pack summarises where we are with the plan, the planning guidance that the organisation has to operate within for the coming year. So we had an initial submission at the end of February of a deficit position of £40.1 million. That was in the absence of any national guidance, which has only just been published on the 20th of March, it's worth noting. We've since submitted an updated position in March with a £28.1 million deficit that does incorporate, as you said, David, the cost improvement of £12.1 million, which is about increasing our level of productivity, reducing handover delays, increasing hear and treat. We've refined our activity growth assumptions so they're not as high as they were, which increases our general risk, because if they were higher than we're anticipating, then that presents a risk. And we've also identified further cash releasing cost improvements that we can make in the organisation. Commissioners have additionally, since that submission, confirmed that the organisation will receive an additional £2.4 million for heart. And as Simon said earlier, we have our next submission due by the 2nd of May, but this is very nearly a daily conversation with ICBs and region and between ourselves as well. So this is a fairly hot topic, but quite late this year, it's fair to say, and I think that's reflective of the national challenge of trying to achieve a break-even position. And we are but one part of it. The planning guidance itself is interesting when we reflect on the piece we just heard around the strategy, because what that says is that we have to achieve Category 2 response times at a 30-minute average across the whole of 24-25. Moreover, we have to maintain the 23-24 ambulance capacity levels, which is an important consideration if we're thinking about break-even. Again, emphasis on workforce, digital data, significant announcement in the budget recently around the levels of investment that are going to be made in the NHS are all around capital investments in digital and data. So very important for this organisation, as Simon said, to get on the front foot with how we exploit that investment to achieve more efficiency. The operating assumptions we've got in the plan are that we will see 2.3% activity growth. So this is what our expenditure, our cost base, will achieve. So 2.3% activity growth, which is in line with our long-range forecasts. We are confident that with that financial plan as submitted, it would achieve a C2 mean response of 30 minutes throughout the year, whilst maintaining patient safety levels. It does depend on increasing hear and treat to 16% and reducing handover times. It also anticipates the reduction in reliance on private ambulance providers. Another key ask of the national plan is that the NHS overall reduces its reliance on agency. And within all of that, there are some key risks. So this does require us to accelerate the delivery of the strategy. That requires us to work collaboratively with our key partners to help achieve that. And of course, if activity growth does exceed 2.3%, then that is a risk to the system that we as a system will have to manage. That said, the strategy does sit very well within this planning framework, notwithstanding the overall financial challenge that the overall that the whole NHS is working with.
Thank you. Detailed report, and I think clearly some challenges ahead. Simon, is there any, we're in the midst of discussions with our commissioners, so we are limited to what we can say at this stage, but I think it's important the board you at least note what the position we're in, and any headlines from you, Simon.
Yeah, thanks, and thanks for the reports. So I think I'd go back to the point I made at the start in my remarks. We need to hold in our heads over the next few weeks the balance between what is a very high pressure environment on delivering on the money, with the need to maintain performance and the need to balance that performance also with delivering a good quality service. That's our iron triangle, so to speak, and I think it's going to be very hard to land all three of them, but that's our task. So today I really, both Simon and I are asking you to note this and note some of the variables that will be in play over the discussions that lie in the weeks ahead, to elucidate or to give some slight colour to those challenges. We're currently at the moment being asked to up our levels of SIP. I won't go into too much more detail than that, other than to say clearly there comes a point where you can increase your SIP, but that comes in itself at a cost. And that's the discussion, that's the pivot point of the discussions that we're now starting to get engaged in. We will do a little bit further on the kind of how we're framing that debate in the private part of the board today, and to reassure board colleagues, we will continue to involve you before we make a final submission, so that people can be cited on and feel comfortable with the risks that we are having to incur. One last thing from me on this, and you've seen it there. One way in which people cope with this sort of very challenging scenario is they add more and more items to the list of the things that you have to believe in order for the plan to stack up. And probably the key thing that we need to be wary of is just not ending up with too many of those things. I know that sounds quite parochial, but if you end up with a list of assumptions that, you know, maybe 9 or 10 strong that you have to believe all come off in order that you can hit a specific number, that's generally a bad place to be. So I can already say, you know, we're approaching the limit of the number of things that we can believe and still look ourselves in the eye and say, we've got a credible plan. That's probably the way I would frame the debate that we need to have. And with that, I'm going to suggest that if it's okay, people just note the report, and we will then pull people back, firstly into a private discussion this afternoon, and then for more seminar time as we need.
Obviously, we'll then come into the public domain. I think it's important that as a board we are united in our support of the, and in setting the negotiating limits, as it were, for the executive team. And we do have to balance, we have to be responsible with the public purse, but we also have to be very responsible as well with the quality of care we give to our patients. So that's a tough balance, and that's what we've got to do as the boards, and we have to test out all the assumptions and make sure it's realistic. What we mustn't do is make false promises. So that's what I would hope. So there's clearly some interesting times ahead. So there's a process for that to happen, and it will come into the public domain at the next meeting. Right, let's move on, if we may, to the report from the Finance Committee Chair. Howard, any highlights that we haven't covered already?
Yeah, so from a financial performance point of view, obviously we've covered all that. But I would point out that that is the fourth year in a row that we've hit our financial targets. So as you rightly point out, that is a very good performance and illustrates control over the finances. We share the concerns around the 24-25, and we're obviously going to be looking at that at the next FIC as well. The fleet update we received, we were assured regarding the engagement of our staff in the selection of the fleet vehicles, which is going to be critical, which we know was an issue last time. And we're aware of the recruitment challenges for the vehicle maintenance technicians, and hopefully some mitigations that are in place to help with that, including an apprenticeship program. On the private ambulance providers, I was, and I think committee was, struck by the level of concentration of PAPs, in particular in Paddock Wood and Guildford. And so although we support the proposals to effectively reduce or eliminate the PAPs, we would make the observation around the careful management needed in those locations, given that we know from an estate's point of view those are two of our possibly most challenged locations. So just needs careful management. And when I say concentration, I think of the PAPs, roughly 20% of them were in Guildford, and 18% I think in Guildford, and 18% in Paddock Wood, with the others being relatively small. So that's an interesting observation. Obviously, we need to be just aware of that in terms of our strategy going forward on those. That was pretty much it, really. Obviously, operational performance was exceptional, and the committee congratulated the executive on the tremendous improvements in performance over the year. But yeah, excellent.
Thank you for that. And just you mentioned about the fleet team. I have to say I mentioned it in my last chair's report, but the work we're doing to engage our staff regarding the new ambulance fleet is really good, and I think gives us a good foundation for the future again in terms of engagement with our staff. So some really great examples of really good work there. So let's note that with pleasure. So any questions on the Finance Committee or what you've heard on finance matters? Okay, thank you. I've been suggested we take the break now, and then we'll come back refreshed for the really important items of our people and culture items. So if I can suggest, it's now 25 to, can we have a speedy 10-minute break, please, and be ready to be back at 11:45, refreshed to handle people and culture and many other things on the agenda. So thank you for your time so far. Right, colleagues, just before we get moving into people and culture, what I omitted to say, what I omitted to say at the start of the meeting was this is a meeting in public, not a public meeting. I normally say it every meeting, but I was somewhat overcome by my own personal news not to mention it today. So that means that any questions from the floor, from the public, are related to the items on the agenda today. So just so we're all clear on that. Right, moving on to the most important matter around people and culture. So I think Tina, you're going to Tina and Sarah between you are going to lead on this item.
Yes. Does that work? Right. Okay. No, that's good. Thank you very much. So thank you, Chair. I just want to sort of introduce the culture transformation sort of programme and some of the highlights around that, and then I'm going to ask Tina to talk in a bit more detail around the staff survey. So I think in terms of the culture transformation programme, it continues to focus on 3 aims: building trust, increasing communications and engagement, and developing our leaders. So I think we can see good progress has been reported in all areas, and particular highlights to include are Simon mentioned earlier the successful launch of the recognition and reward platform and Star of the Month, so I think that's a real positive to note. Also, the Big Four conversation webinars, we were very successful with over 200 views per session, and that's linked to the work of the staff survey. Also, the 51% of first-line managers completed the fundamentals of leadership training, which again is really important just in terms of developing our managers. And then Tina's going to take us through in a bit more detail the sort of national staff survey results, but really to say a big thank you, I think, to all the staff who gave their feedback, which is so important. And we got over 60% of staff, so that's over 2,800 colleagues to actually complete the survey and the feedback. So I think from there we recognise that there is work to be done, but there's real positive improvement in the staff survey results that I think we should be celebrating. And I think the basis of where we take it from here is obviously the important sort of continued engagement with staff and in those discussions going forward. Just in terms of the statutory and mandatory training and the appraisal process, I think we've, just moving down to that, reported the appraisal rate, which is steadily improving to 65.5%, but obviously it remains below the trust compliance target at 85%. So there will be a focus on appraisals and increasing that compliance rate, including appointing the RSM auditors to undertake a review of the appraisal processes. And I think that will help us to look at what are the systems for recording appraisals, as well as, importantly, how effective they're deemed to be for our staff, because it's got to be valuable. So I think those are the main areas that I wanted to highlight. Was there anything else that you wanted on that particular paper? Yeah.
You'll have to switch off.
Okay.
So thank you. The only other thing I thought would be useful to add, particularly in staff survey, and it's covered in so many papers, I'm not going to go through the detail of it, the information is there for you to look at, is while we've seen a statistical significantly improvement, I've got that around the wrong way, in all of the themes, the other thing I've had the chance to do is to go through all of the free text, as all of the executive have, but I've been able to really do the thematic in the same way I did last year. And having done that, first of all, 123 positive comments, and not just my manager's great, but everything else. Actually, it was a lot about my direct line manager, and also the sense of change. There's things that are being done differently. There's a different approach that the organisation is taking, and people are really noting that. So I think 123 comments like that is a really good thing. The other thing is that a lot of the themes that have been sitting around for a good sort of 5-6 years have shifted. I didn't see a repeat of those themes coming through. Some of them are still there. Our rotas still cause problems and is something we continue to explore and look at. But the other themes really have settled into a couple of main ones that become part of our strategy development going forward. So it's positive to see that the range of issues has reduced. The sentiment around those issues has reduced as well, so it's much more targeted, and there is more positivity coming out in that free text. So I just thought it was worth adding that, along with the papers that you've received, and I'm happy to take questions, Chair.
Colleagues, questions, important point. I mean, ROSAs, I think, is something which even in the best of organisations, I suspect, will create some tension, because we know you can't please all the people all the time. But some of the other headings you were referring to, people feeling safe at work, people feeling that they were being listened to, they are key, really, I think, in terms of whether we are becoming a healthy organisation. So, Sue, was there any comments you wanted to make as Chair of the People Committee?
Yes, thank you, Chair. Sarah, it's day 3. You haven't sorted it all out already? Surprised about that. Anyway, no, thank you for that report, and thank you, having to get to grips with that very quickly as well and give us a summary. And thank you, Tina, for the summary of the staff survey results. It's really good to hear about the text. And I think you got some challenge on this at People Committee already. And as we said, the gift of People Committees that we always ask you to do more work. That's our present tool to you. So we've asked you really to go away and look and cross-reference that in the existing housekeeping work that you're already doing with what's come out from the staff survey now, both in text and in the theme. So thank you for doing that, and we look forward to getting the update on that at the next People Committee. My challenge probably is something that we raised also at People Committees around the BAF and the Goal 3. And we thought, I think collectively, that it was a very ambitious green rating, and I don't think we see that as a green rating. The appraisals are not where they need to be. ACAS, it's very early days. Green shoots, very good to hear some positive work, but it is early days. And I think the fundamentals, it's 51% have completed it. We are not at completion. So I think that's a very optimistic, doesn't actually reflect where we are. So I think I'd ask you please to review that rating and I think make it a more realistic one, please. So I think those were my key questions on that. Thanks.
Yeah, thank you, Sibo, for that. Because I think the important thing for me, I think in the early days, is to, really look at and focus on the areas that you've said and put into place that action plan to actually deliver that. So I'm expecting to be able to come back to the People Committee to update in more detail on those areas. Thank you.
And on the sort of next question about appraisals, and all I ask is perhaps as a parting gift to me, Simon, that this is one of the areas where can I ask I know you have given leadership to this, but you continue to give your personal leadership to this issue. And can I ask that we find a more straightforward way in which our people can engage in the appraisal process? It's more about the conversation than it is about the paperwork or the virtual reform, and it really is a meaningful conversation about the hopes and dreams of our staff and how we can fulfil them and what feedback they have about their boss. We really want to make that as an open, general conversation and trying to get away. And much as it's such an important conversation, but it tends to get lost in process. We've never cracked it. It's certainly my time here, and I do think it does need another push, as it were, but it needs a push with meaning rather than not just chasing the numbers. So I think that's all I would ask, Simon, in terms of, as a parting gift, if you could give this a personal boost to our HR director and others to get this appraisal process right, and about the reason we do it.
So as a parting gift to you, David, how could I deny you anything?
That's not. This is not rehearsed. It just comes to me in that conversation. Subo's comments.
So,
we need to crack this, don't
we? That clearly has to be said on the record. So I will say that. I mean, leaving my desire to help you exit the organisation in a really positive way. The other thing I would say is I think the engagement of our internal auditors on this process is a helpful, more disciplined review of what the issues are. There is, I think it's worthy of that consideration, and so I hope it's not exactly a parting gift that's delivered results, but the fact that we are placing it on the internal audit list of things to do, I think gives us the gives us the impetus to try and make sure that the board will consider it and the recommendations that come out of it. So I certainly make the commitment that we will consider that report at the board in due course. I think the other thing I would highlight is that we've got to make this not just, I think you were saying this, but I'll amplify it, something that people want to do, not something that we are flogging them to do. And I think that's the key. You can see some signs in the data, they're not yet consistent, that people are starting to have that type of conversation. I personally was quite heartened by the more positive comments about immediate line manager, because it doesn't matter what we do. Most of the decisions, most of people's lived experience in this organisation is by OTLs managing groups of people, and it's they who have to get that conversation in the right place. And so I promise you that we will make it a focus of the year ahead.
On the fundamentals programme, I mentioned in my report, but David and I were privileged to attend, as my non-executive colleagues have at the end of each cohort of the fundamentals programme. That also gave me heart as well in terms of the commitments of our staff, and these were junior managers in the organisation who were getting some leadership development and were buying into the cultural changes and everything that you were trying to do, Simon. So that really gave us, I think it's fair to say we both took heart from those conversations. So I think implore your colleagues as well to really keep moving on that fundamentals programme and other similar programmes we have around leadership development. It's all part of the cultural transformation. Any other comments from you both? Okay, can we move on then to the again important item relating to our culture around the Sexual Safety Charter, the gap analysis. And Margaret, you've done some very important work here with staff in this area.
Thank you very much. So you have the paper in front of you, and after signing off the charter, which the board did, the Sexual Safety Charter, published by NHS England in December, the steering group immediately set to work to do a gap analysis across the 10 points, the 10 principles of the Charter. I have put the gap analysis there in full, but we took an approach of what good looks like, what would we expect to see, the strengths that we know about, gaps, and then the actions. That then informed us on the setup of the work streams, and we have 5 work streams, and I've listed them there with the leads, with key people that can drive the progress. And I have to put down on record that I've been really impressed by the drive and just the getting up and doing from the staff involved, and people have really wanted to be engaged, which shows a real willingness to turn away from the willful blindness that I think a lot of public sectors have had in this area. So the 5 areas are data, communications, policy and process and reporting, training and MDT welfare processes. Now, added to that and relates to the comments Simon made in the Chief Executive's report, the unique vulnerability of students has really surfaced through. So we already know from many, many examples that the student cohort is a quiet cohort that does suffer as they come out into our services. So that's the ambulance sector as a whole, not just CCAM, whereby they don't know that it's okay to speak up, and they come in expecting a certain amount of behaviour. So quite a lot of work is going into this, and we were looking at including a further work stream on students, but in fact having really gone through this with Neil Monnery, who leads the student university links for the clinical education, and then our own FTSE Guardian. We have a number of forums that we're developing and have set up, and the one of the ones that I would highlight for the board is we've just started with Brighton University, invited us in, and Kim Blakeburn went in and carried through an exercise with their Year 2 and Year 3 students, similar to the exercise we had at the last board development session on speaking up, where it was based on case scenario, and it was around speaking up and the right responses, and really set the tone of what can be expected and what should be expected, and the routes of speaking up, with Foot Super then being one of the final default tools if they find they're not getting the right responses. So progress, really confident that by July, which is when NHS England expects us to be able to comply to the Charter, that we will be there. The critical factor for us has been the policy. It's good to know the policy has gone under consultation, quite a lot of feedback, and it comes to JPF in the next couple of weeks to be signed off. now with the policy, the other areas have been able to really push through now in their plans. And there is no area that we're concerned about not being able to meet. The amount of conversation and narrative in the organisation has increased incredibly, actually, just over the last months. We've seen an increase in concerns being raised by students, by newly qualified paramedics, and through universities themselves. We have seen a lower tolerance, and I thank my executive colleagues and Simon himself into the approach that we're all taking to this. So whoever is accessed, we are showing the same level of tolerance, which is incredibly low, to any level of banter or harassment. We know of terms like sex for sign-offs, which is a big factor for students, and there has been an increase in suspensions related to a number of different sexualized behaviours and things that in the past would have got away with. So smacking someone's bottom as they come past, things like that have resulted in quite significant responses. So that is working its way through the organisation, those messages, and it's interesting to see that the conversations are being held at all different levels. One of the things that did strike me, and actually it was confirmed in Michael's challenge about the hard-to-reach groups, one of the points is about intersectionality. All of the cases we've seen so far are around males on females. We know with a population of 5,000 and with the diversity that we have in our population of staff, that there will be female on female, male on male, and there will be female on male abuse. So that was opened up in the conversation we had, the big conversation, that will be there. We're just blind to it, and also there's a lot of stigma still attached to it. But it's interesting to see that those conversations are starting. We haven't actually seen any reports, any concerns raised yet, but I think give it time and it will. But one of the things I think I've just talked to Max about is we need to start going into our staff networks and having the same open conversations as we did in the big conversation, to really say we want to hear, we are listening, and we will do something about it.
Thank you for your leadership on this matter as well, Margaret. Colleagues, questions, comments, endorsement? Liz, first of all, then Subo.
Thanks, and thanks, Margaret, and fully support this. I guess my concern is around resource to drive this through. I note your work stream leads all have full-time roles within the trust, and the amount of time and dedication and the very tight time frame to drive this through. Are you confident you have adequate resource to deliver this?
I am confident we have resource, but you are talking to someone that's used to working in fast situations, so I'm used to fasting all the time. I am confident, and I've had nobody wave to me that they're struggling, and it is a question we do ask, are we able to do it? And certainly the milestones we've set ourselves, we've met so far. Really, the challenges are more around, we have got wide representation in all the groups. The challenge has been around getting the policy through, actually, rather than a resource issue. We did have a conversation as to whether we needed to bring in a specialist, and we haven't done that, we have had. We're quite lucky in the CFR team alone. We have somebody who's a specialist in this area and is certainly giving us some support and advice. But we do know in training, for example, that we do need to go out of house for that, and we also need to have the general training for staff, but also specialist training for our HR teams, and then also for our senior teams, who are the ones that are dealing with the responses. So, for example, the multidisciplinary panel that hears any allegation. We need to be confident that our understanding of all the intricacies, intricacies, whatever that word is, in the nuances in these areas are understood, acknowledged, accepted, and that our biases are continuously being challenged. So it's resources in that way is what we're looking at, rather than time resources.
So obviously something about education, Margaret. We did start a programme of making us all aware of appropriate behaviour. Is that continuing in the organisation?
That contract actually finished in February. We've had really mixed evaluations to it. It's not one that I was involved in at the start, but it has ceased. We feel it's done what it was brought in to do. We're now looking, we already have the proposal for all staff awareness, education, understanding, which includes the bystander. We do have a bystander toolkit, but you'll see in the gap analysis, we don't believe it's strong enough. People can't navigate to it very easily. And again, there's a lot of training out there. So it's just plugging into the one that's the best value for money, but actually will give us the best value in education, the right pitch for our staff, because that itself will have cost benefits down the road, won't it, in many ways.
Thank you. The important thing is, though, it's been looked at. That's the assurance I'm looking for. There's a process being put in place to continue to educate, because what people can't be is claim ignorance in this area, and we must make sure we remove that excuse of any inappropriate behaviour. So that's important. We do that. Subo.
Thank you, Chair. Thank you, Margaret. It's really good to see this and, progressing. And I share Liz's concerns to make sure that you've got the right resource, really, because there's quite a lot in here. But thank you for focusing on that, to try and get it done by July 24. May I challenge you a little bit? So you talk about zero tolerance in this paper. And I'm wondering whether you need board support to really set that out. What do we mean by zero tolerance? Now, we probably all have a good understanding of it. I do. And if you look at, lots of other examples, British Transport Police, I walked into Boots the other day, zero tolerance. Any verbal or physical abuse, immediately it is reported to the police. So that's my sort of stance, really. Any kind of verbal, never mind physical, sexual or sexualized behaviours, that results in dismissal. So my question is, first of all, do you need board support to help you define that zero tolerance approach? And then my second question is really, there is a natural alignment with gross misconduct. And so there is another policy around our disciplinary policy, and that our gross misconduct has actually defined this is what it is and these are the consequences of it. And, I've been here 3 years. I've been the Freedom to Speak Up lead for 3 years. I've heard these sorts of cases consistently for 3 years. We really have to stamp this out, so there has to be a level of urgency about stamping this out. And that, for me, means much more forceful sanctions as soon as we hear about this behaviour and it is consistently applied.
Thank you, Suba, and I know we've talked about that before. So, we can provide evidence from the last month where we have suspended 2 colleagues on the back of a verbal banter that was given to a student. So that no tolerance is there. And the policy clearly sets out what the definition is. It is a no tolerance to any unwanted behaviours. Now, the challenge is in how people interpret, or so it's the response. So we had this discussion last board, didn't we, around speaking up. We need to reset part of the work, which is the biggest cultural piece of work, which is why this sits in the culture, is the resetting of the moral compass of what is acceptable and what isn't. So if a young female, which is what it is in this case, but I'm sure it happens to male, comes past you, it is not acceptable to smack their bottom or touch other parts of their body, which are seen as intimate, and it's just not acceptable. So we have suspended somebody on that. So the message is coming out that there is no tolerance to this. Now that is having its impact, and Emma will tell you that the suspension numbers have doubled in the last month, 6 weeks. So it has got its consequences. The investigations then kick in, and that's where we need that MDT panel to be completely cited, and we need the right level of understanding across our HR workforce and the teams that are likely to do the investigation, the individuals likely to do the investigations, so that thought of no tolerance goes all the way through. Some of it will, though, end up in education, in the conversation of, not acceptable, we will watch and wait. There are different levels, so we cannot. What people have been asking for, and they did at the big conversation, is, well, what does zero tolerance mean for every single case? Every single case will have to be taken as a single case, but it's about the consistency of application and thought and rationale behind every single one. And that's the most important thing, which hasn't been available here, I think, for a very long time. So people will be able to point out over the years where, no, there was a dismissal, there was a suspension. The trouble is we haven't been consistent with that. the trick now is to all understand what zero tolerance means, and I think this will come back to a board development session at some stage with some examples, because I think that there are already some challenging cases that we need to be quite clear about in practice what does this mean for us. And of course, some will lead then on to consequences of dismissal or gross misconduct.
And let's be clear that there are other boards. We could be the guardian of the processes in the organisation, make sure there's good processes in place, they're fair and open. It's not for us to, I think, let's keep off setting the tariff for it. What I want assurance about, what the board gets assurance about, there's a fair process in place to make sure that all is, we're dealing with all these issues in an appropriate way. So it's important. Yeah, Michael?
Just very quick, I know time is of the essence. Really support this. It's really, really excellent and, 100% behind it. Can I just one other question related to that? So, arguably, where people exhibit these sorts of behaviour, they are a symptom of something more deeper. And I just wonder, is this linked to all the stuff that we're doing, training we're doing on unconscious bias? Because people can stop behaving in that way, but the innate attitude to women or other groups is still there, and it manifests itself in different ways. And the thing that I've been struck with in my 5 and a bit years here is I still get this thing around, well, I did think about putting myself forward for promotion, but somebody said to me, this is a woman speaking, yeah, but it's not your turn yet, it's the blokes are coming before you, so don't even try it. I'm exaggerating that for effect, but I still think it's there, So it's a question of, are we getting it, the unconscious bias stuff linked with dealing with?
I mean, this is where this sits so much at the heart of the culture, doesn't it? And the whole speaking up thing. We know we've got a big problem in society, haven't we, with misogyny, for example. So CCAM isn't going to sort it, isn't it? No. We're not going to get to a perfect world. But we do, there is in the blue light, there's a lot of facets in this, which is why it's really important it sits within the cultural space.
I know it's a society issue, but I am struck, to be honest with you, coming to this organisation and other organisations are not like that now. We are a bit behind the times in this space,
And I don't know that it's behind the times. We were talking about this yesterday, Tina, myself and somebody else. It is far more intense here. I've never come across anything like it ever in my 42 years in the NHS. It is more intense, but equally it's quite a unique service we provide. There is no other provider that has 2 people in a cab for 12 hours a day, every day. So, it is quite a unique service too.
But I know you come from a military background. I haven't seen it in the military to the extent to which I've seen it in CCAM, and you may disagree, but I find your military background. No, somebody was military background, I don't know, forgive me.
So just to conclude this debate, thank you for the comments firstly on resourcing. I take those points. The board will have a chance to look in June at the programme of work we propose for continuing to address the issues around culture. And clearly, while we need to have a necessary focus on this as a topic because it's become so prominent within the NHS as well as within the ambulance sector, we're also investing resources into that programme. And I am cognizant of the fact that we don't want to separate out too many separate strands of programmes. But I take the challenge that both of you have raised about are we resourcing it adequately, given the context of the work that we face. The second thing I'd say is that this is something that has been endemic in all emergency services for a long period of time. The ambulance sector is obviously the latest service to receive a report. Before us, there have been the police and fire services, all of which I'm sure, as board colleagues are aware, have had high-profile issues. I draw that out not to make a critical comment, but to say I think there is some learning for us on comparing notes, because although Margaret said we're the only service that has 2 people in a cab, I was thinking, well, so do the police. So do the fire. I was just thinking there are other people where people are, cooped up together in small spaces for quite long periods of time. And I think there is learning that we need to start to share. because some of the issues that I think are transcultural relate to the context in which we're operating. The third thing I think to say is there is a risk that this becomes a narrative around detriment. And what I mean by that is what we're doing, and it's necessary that it is, we're asking people to speak up when they've had a bad experience, and that's really important. But one of the things I think we also need to do is we also need to be better about celebrating the diversity in our different staff communities. So to that end, I've asked for the awards ceremonies this year for the networks to promote and agree an award about people who they wish to celebrate, because I think we also need to be focusing on a positive narrative about what different communities bring to the organisation, and starting to celebrate that in our most, central awards event, I think is a really signalling step for us to be able to take, that this isn't just about tell us when you've had a bad experience, which is really important. It's also about we value you for what you bring to the organisation, and we are publicly going to demonstrate that.
Thank you. So, colleagues, I think we note the work that's happening. We thank you, Margaret, for your leadership. This is a board issue, though this is this is an issue for all of us involved in leadership. It's about setting the right tone. The tone starts here at the board, in the sense of setting standards for the organisation, what we expect of each other, but also then what we expect of the organisation. It's a leadership issue. But also, we mentioned we're unique that we have two people in a cab. Well, I don't want to also demonise the people that work on our front line. We've had issues in corporate departments, in call centres. We've had some bad behaviour across the organisation, and it needs to change everywhere for the better. We need a positive culture for everyone that works in CCAM and our partners. Whether you're a paid member of staff or a volunteer, we all have to work to the same high standards of behaviour, and cherish the contribution we all make to the organisation, and not abuse people. So that's something which I think is a standard we're setting from the board, and we expect the organisation to follow. I really feel I'm beginning to be more assured now from the chair, having listened and witnessed these issues, that we've now got the executive will begin to get a real grip on this, together with the leaders in the organisation. That's something which I'll take comfort from, because it's so important. Subo, for the headlines for the People Committee report, please. We covered most of it, I think, in terms of...
I think we've covered most of it, Chair, so I don't need to say anything further.
There's nothing you need to say for an exception. So, okay, thank you very much. Moving on now to the important item of quality and safety. Margaret, you want to introduce this? Oh, sorry, Richard.
Thank you,
This is a
Chair.
learning from death report.
So I'm introducing the patient safety report, which includes the Learning from Death's quarterly report as well, and then I'll pass to Margaret for any comments from the Quality Directorate. I'd just like to draw the board's attention to two items within my report. The first one is item 3, Paddock Wood Medicines Distribution Centre, which I feel that the narrative does not do justice to the seriousness with which the board is taking this situation with the poor estates at Paddock Wood Medicines Distribution Centre. And I just wanted to explain that the reason why the Task and Finish group was paused was because Simon's new in post as the SRO, joint SRO with myself, who's new in post, and we've just recruited a dedicated project manager to that project, who needed some time to get up to speed with what the current situation was. And I just wanted to assure the board that we've addressed the immediate safety issues for staff, such as the leaking roofs, the damp walls, the doors, security doors and shutters into the unit. They've all been addressed from a safety perspective, and now we're concentrating fully on the situation regarding the lift and the health and safety elements of moving crates up and down stairs and things like that. And we'll come back to the board with a firmer timeline when we've got that from our partners and architects. And the second thing, a really positive story at item 4, which is essentially saying that we now have within our critical care department real-time quality assurance data, same-day review of how our critical care paramedics are managing our most seriously ill patients, which provides real-time and immediate feedback to those clinicians from senior managers. And I think it really puts us in a good position for our rollout of supervision across the rest of the organisation, because if we can model this through our smaller service critical care team, it provides us a fantastic model for when we start the supervision with the wider clinical workforce. So I just wanted to celebrate that success. They've implemented this themselves with very little oversight from above, and it's a very successful project, and I just wanted to celebrate that. And I'll pass over to Margaret.
I thought just on that point, I mean, we're a highly professional workforce, and I think it's so good to see that coming. And why, going back to Margaret's the previous item, which Margaret introduced around sexual safety and the way people behave in the organisation, it really is why we really have to emphasise and rework on the professionalism of this place, and the fact we have regulated professionals in the organisation who need to behave to the standards, but also be helped to supported to behave in that way. So that's why the two are linked, aren't they? So it's really important we do make that link. Margaret, over to you.
Thank you, Chair. So I will draw you to point 6 and point 7, which both took hopefully your attention to some of our metrics that have changed over the last couple of months. So in regard to incident reporting duty of candour, you'll know performance dipped in January and February. We also saw that in the compliance of review of risks, actually, which is an audit that's come into the audit committee next time. This is an intended consequence of bringing in the big system, Datix Cloud, into the organisation. There were some technical issues. We did have to suspend it for a little while and brought it back in again. We are very carefully monitoring that we didn't miss any harm events or any safety events during that time where a number of records were lost, and nothing has been picked up since. It's been looked at in 3 different forums, and there's been nothing picked up. You will also know, and I've mentioned it numerous times, around the infection control, so this is point number 7, that has been really variable, and you'll see that in the table over the last year in regards to compliance to audits. And our quality assurance visits that have now taken place in 75% of our units have consistently exposed a lack of understanding compliance, a lack of a good attitude really towards infection control. Now that's not been helped by our structures, and it relates to what you've just said, Chair, which is we need to make it relevant and easy for our staff. So the IPC team have been working with quality improvements and brought in an improvement which will kick off in April, where they have a completely different approach, which is very easy to access through Microsoft questionnaire, and will hopefully not only increase the understanding and therefore the compliance, but make it a lot easier and make it a continuous process. We have also been reinstating the local IPC champions, so again, I'm thankful to the operations teams for enabling us to do that. That's really important to continue to raise awareness and understanding. Thank you.
The recent national chairs meeting, your professional lead, the Chief Nursing Officer for England, was making a particular point about infection control and the rebooting of the guidance. So something which I'm glad we're on to. So thank you. Colleagues, any questions, comments?
Thanks. I just wanted to draw people's attention to the Learning from Deaths report that Richard had put together, and just that to know, and the link to our strategy, that the main concerns are delayed response, and that leads to decreased patient outcomes and at times patient death. So I think all the work we're doing on our strategy to improve that level of response. A 30-minute mean is still a long time to wait for a critically ill patient. And if we can exceed that by using our strategy and diverting those patients who don't need that immediate response, that will make a difference. And that's also been noted by our coroner during inquests. So I just wanted to knit what we're seeing as actual results from Learning from Deaths to our future strategic direction.
Thank you, Chair. Thanks, Richard, and thanks, Margaret. That's really helpful summary. Can I just ask a couple of questions around medicines governance and the PGD compliance? So when I look at the IQR, we've got number of controlled drug breakages as 16 against a target of 0. And PGD compliance, I note it's increasing, but we're still only at 89% against the target. And that's been going on for 6 months, but I'm not sure if if the actual data reported is accurate, because it's given an October figure instead of a February figure. So I was a little bit unclear which is the most recent. But I'd appreciate some sort of context around both of those.
Thanks, Subo. So we are concerned about the controlled drugs breakages. It's higher in our service compared to other ambulance services, and it's higher when you compare it to other non-ambulance services in the NHS. We've looked into it, and we're still not particularly clear why it is, and all we can see is elements of careless behaviour when glass vials roll off of benches and smash on the floor and those sorts of things, rather than any underhand acquiring of CDs by colleagues. But nonetheless, it's one of those questions that are still unanswered for us, and we're still looking into. We've now recruited a medicine safety officer for the first time in the service, Emma, and one of her key pieces of work is to try and understand why our CD breakages are higher than others in the sector. So we'll come back when she's done that piece of work. And then around the PGD compliance, again, we were concerned by the figures as well. There is an element in here in terms of recording. It goes back to the discussion we had around appraisals and ESR and all those sorts of things. Again, recording of PGD compliance has been weak, but it is an area of focus for us now. And as you can see from the report, the PGD dashboard is going to be something that our operational leaders will be using as a key tool for understanding which staff have and haven't signed off their PGDs. So we think that we have a strong feeling that the lower figures and the incorrect data around the months is more to do with the fact that it's not being registered on our systems rather than they're not compliant with their PGD. And of course, we as a trust would not support any clinician using any drug when they're not compliant with their PGD, and we would take that very seriously if that were the case. So we hope to see an improving picture with the level of focus that we're putting into the project around PGDs.
I think we can take then partial assurance that this is a matter that's being given appropriate attention. So thank you for that. It's very, very important. Any other questions on?
Can I just go on the PGD piece? This obviously came up in a committee in December, January, when we started really focusing on it. And there's been quite a lot of work done. We've seen just under a 9% increase in compliance with PGDs in the last 2 months. And some of those operating units that were particular outliers, we've seen over a 10% improvement in that month. So we are putting more scrutiny on it and at the right level around particular people as well. So that it's really being prioritised across the teams.
Any other comments? Paul?
Yeah, just a very quick one. We heard about the importance of complaints from our patients, and there's a study into that now with interesting consequences. We just wonder if you give us a heads up on what you found there.
In the deep dive from the complaints, yeah. So the deep dive was done on the staff attitudes, and is an action that was agreed for in People Committee. And that's come out with some really interesting, I don't want to preempt the Big Bang for People Committee though. So the paper's going to People Committee, but two of the interesting things I mentioned earlier today, which is first of all, the old DATICS categorised safeguarding referrals, for example, as a complaint against staff. So that was an interesting one. So if somebody was unhappy a safeguarding referral had been made, it would be put under staff complaint, a complaint against staff rather than a safeguarding theme. So a whole percentage of the complaints that were lodged against staff attitudes were actually not about staff attitude, they were about other things. And then when we did get the final tranche, there were staff complaints, staff attitudes, there were two big themes. One is the attitude of crews to care home staff, and we know where that is targeted to, so there are some hot spots of that. And the other one was the attitude towards patients, where the crew felt that they'd been sent to an inappropriate call by 111. So both those things mean we can target actions in there. We also looked at the number of staff, the individuals who had numerous complaints against their name. We compared that to compliments. And some of them, for example, there's one gentleman where there was 9 complaints over a period, but they'd had 16 compliments. So there's something kind of going on there. Those are going towards conversations. So we've noticed that a number of complaints and compliments are coming through in your name, or just a number of complaints. Can we talk about this? So we're setting out now, and we're going to have that discussion with the local leaders as to what we think is a fair number. Having the odd one, of course, locally, we look at it to see if there's anything in there. But if there's a pattern, then that tolerance for that needs to be quite low too. You know, I have to say it's not a usual thing to have a complaint made against you by a patient. It's quite an unusual thing. So we do have to pick each one individually as important. But I think those that there is a pattern, and we were quite surprised at the number of individuals that have got quite a lot of complaints, their names pop up quite a bit.
The important thing is being looked at, and it is to come back via the appropriate committee. I'll just conclude this. Liz, I know we haven't got a policy report this time because the quality committee meets next week, but you have met to discuss the quality account. Is there any headlines to share with the board as just assurance the process has happened?
Yeah, we had an extraordinary meeting to discuss our future quality accounts, which we will take to the quality committee next week, and also to bring the closure of last year's quality accounts as well. So that will come to the next board that we hold.
Important. We have a quality account as well as the financial account. It's important well, we need balance. Yeah, thank you for that. Let's move on to the next item. Richard, is there any more you want to say about the Learning from Death report? Sorry, Howard, do you ask a question, or is it?
No, the report's just for information.
Thank you. And you've had Liz, as chairman of the Quality Committee, did summarise the findings in that report. Howard?
Just one question on the Learning from Death report, and I don't apologise for asking the same question on repeated occasions, and that is my concern over the fact that this is marking our own homework. So I think last time there was reference to some other external parties being part of the process, but there's not. I know it's a structured judgmental review, I understand that, but all the people listed in there are all CCAM people. To me, I find that a bit odd, that there's no external review on that panel. And I think last time, as I say, I think you mentioned there were, and this time there aren't. So my challenge is, I do think there should be some sort of external input to that review.
Richard, any comments?
Yes, so last quarter, you're right, we brought in East Midlands Ambulance Service to do an independent peer review of all our processes from start to finish to do with learning from deaths, and they were satisfied that we were in line with national policy. But I take your point that we could bring in an external person onto our panel. There's no reason why not to do that, and in fact it might be quite useful. We have found that East Midlands learnt more from reviewing our processes than we gained, other than the assurance that we were doing well. But we can certainly look at bringing an independent person onto the panel. Thanks for the suggestion.
And offer them our services to them as well.
In return, yeah. Yep.
No, I know it's not straightforward, but is there some kind of medical examiner process in acute hospitals, for instance?
Yeah, unfortunately the medical examiner system doesn't include ambulance services at the moment, but the principle is there that external and independent review would be useful. So I take the point and we'll take the action forward.
Thank you for that. Thank you. Right, let's move on now to responsive care. So Emma, you're going to introduce the cover paper?
Thank you very much, Chair. So I think we've covered performance quite a bit already in this board meeting. I would like to echo Simon's comments about this has been an extraordinary amount of work by an extraordinary number of people across the whole trust. It's not just an ops function, because people are feeling better, which we've seen in the staff survey. They are feeling more heard and more valued. That inevitably delivers better care. This is not the outcome of one action. There have been many actions over the short, medium and longer term that are beginning to come together. And I'll use our improvements in call handling over the last couple of months as an example of that. We knew that we had some challenges We examined them in depth, and we came up with a very comprehensive plan that we presented to board committee previously, and we're now in a much stronger position and improving position as we go into the new financial year. So I will probably keep it really brief, because I think we recognise we've done well compared to others, but in terms of absolute performance where patients come to harm because we're not there as quickly as we can, the strategy is absolutely going to be key to making those improvements. And what we mustn't do is now sit on our laurels because we've had a really good year. This is now a case of, okay, we're in the next year now. Let's move forward, let's build on it, and let's do better, because I absolutely want us to see us do even better than we did last year.
The important thing is you're also being open about when we haven't met the standards we set ourselves, and I think that's also an important part of our culture, and we do something about, and we're trying to do something about it. We're not being complacent, and I commend you and your team, Emma, for what's been achieved over the last year in the face of some very difficult operating conditions, particularly with the pressures in the hospital sector and other parts of the health service. We've ended up often being the safety valve for pressures elsewhere, and I think we need to commend our staff for the way that's been handled. Any general points about, before we move on to the specifics, any general points about what Emma said? Howard?
Sorry, it's a specific question about the IQR. Is that okay for now? Or?
We can ask it now, I think. Yes, please.
So, yeah, I mean, obviously, generally, the performance, all the charts are basically moving in the right direction and in many cases, very strongly. So it's great. There is one chart there that I noticed on page 44, which is the ECAL, Emergency Crew Advice Line. Mean response time seems to be heading in the wrong direction. I just wonder whether you have any comment on that.
So ECALs, for those that aren't sure, are emergency crews when they go on scene and they want support from more advanced clinicians, particularly paramedic practitioners. I think part of this has been, my understanding is, the focus that we've tried to use our PPs to do patient support as well as crew support. We need to also recognise we've got our OTLs and people riding out more often, so they may be getting support on scene in other routes. And we're really trying to encourage using the clinicians and community pathways, if those pathways are for referrals, to support some of that decision making as well. So I think there's a multitude of things, but I think it's something we need to look at going forward, because that decision making on scene, we want to move earlier on in the journey, so we do better clinical decisions and support for patients early on, but we need to make sure this is timely and appropriate. So I think the conversations I've had is people getting support from other clinicians in pathways, as well as there are local OTLs and people, because they're doing more ride-outs and they're having more sort of peer support through that route.
Sounds like we're trying to do the right thing by giving our crews support. Maybe we need to look at the measure here to make sure we reflect it accurately, because there's clearly a wide range of supports available when people are in distress, or need help. So let's find a way of expressing that in a more objective way. Subo?
Thank you, Chair. It's not a question, it's a comment. I feel I ought to say, having been asking questions about Hear and Treat non-stop and saying, why isn't it higher? Why aren't we getting closer to the target? I want to publicly acknowledge that it has improved and you are very close to the 14% target. Well done. That is duly noted. And I also noted in the finance report that 90% of the efficiency target was met because of the Hear and Treat increase as well. So double thank you. So I just wanted to say that publicly.
I'm sure that's been well received. So thank you for making the comment. And it's an important part of our strategy going forward, isn't it? So we started, so we'll finish. Yep, so well done for that. Can we move on then to the NARU review? Is there any more you wanted to add on that, Ella?
No, I think the board have got the paper. Michael obviously covered it, because this is the same paper that we presented at FIC for in-depth discussion. So happy to take any questions at this point that people might have not raised earlier with Michael at the FIC chair's paper.
And just to say, for the sake of completeness, the reason why this is being brought here today is a few boards ago we presented the problem statement. This is now the solution statement. So it is coming here for information, just to make sure that the board has now received the plan that has been endorsed by everybody who needs to endorse it. there are some challenges associated with delivery that the committee that Michael referred to will oversee that are not necessarily of our making and more to do with the translation of NARU nationally. But I'm confident with this, the additional resource that commissioners have put in, and we are out to recruitment for the new leadership arrangements as we speak. This is the other thing I think we should probably notate. We are in a good place, I think, going forward. It will be important that the board keeps an eye on the trajectory, because we're not going to deliver 2 teams of 6 day one of this year. That's not real. It's going to take probably most of this year into 2025 before we get anywhere near that, and we need to make sure that we continue our focus on it, because as Michael said, if one marker of confidence in the public have in us is if we can get you when you've had a heart attack really quickly, the other is that when the world has its worst day, we have our best.
No, well said. But I think we'll keep that on the on the action tracker. But I think, you know, there have been some pretty high-profile incidents which our teams have responded to. Not least an incident on the M23 where we did seem to have done exceptionally well in terms of both quantity of people on scene, but also the quality of the work. So I think we've been commended for that, and I think that's really important that we just note. It's one of the things, part of the organisation that doesn't get a lot of publicity, but is there quietly in the background, ready for that moment of challenge you refer to, Simon. So thank you for that. Right, next item, very important item, update on our digital. Please join us at the table. I think, Simon, you're going to introduce this with AJ to this paper.
Yeah, so AJ's here to lead us through the paper, so I think that's what we'll...
So, over to you. Welcome.
I'll take the paper as read, but we will try to summarise for the first time in CCAM what the work plan is actually looking like from a digital perspective for the next 12 to 18 months. So we've summarised in the paper 134 different projects, which sadly is now increased to 145 as of this morning. In terms of prioritising those, the 43 as per Appendix 1 are there. The first half dozen of that appendix are mandated national projects, which every ambulance trust has been mandated to do, so going through those very quickly. Our telephony upgrade happening next Wednesday across Crawley and Medway. The control room solution, we've agreed to go live date for the 15th. SRVs and other vehicles. That work will start at pace in May once Lewis VMC is being refitted out, and that will see all the vehicles going.
Thank you. And we're in a public meeting. I think one thing the public perhaps don't understand about ambulance services was a technology-rich environment we exist in. You know, the vehicles and our staff rightly get attention, but we don't always give attention to the telephony and to the wide range of technology that's in the background, and we are very technology-rich. So I think it is important the board do receive this work plan and really understand it. And Paul, you've been sort of taking a particular interest from our executive team in supporting the technology function. Any comments you wanted to add?
Yep, this is a great piece of work, so well done. Thank you very much. So my questions were 2. One was, have we got the capacity to deliver? Because there's a lot of deadlines in the next few months. That's one question. The other one is, how do we sustain this into the future? But a great piece of work. Well done.
Before your comments?
So just to commend the report to the board. It is interesting. This is what you would call the day. This is the day job before we even do some of the stuff that's implied in our strategy. So that's why this is important, because if we don't recognise that the day job is big enough, again, coming back to the question which we've touched on a few times, and we will need to think about how do we resource doing some of the big strategic development stuff that is going to be critical to the implementation of the strategy at the pace which we now need to do this. So I wanted to just acknowledge again the quiet but essential contribution of the team. We've now, touch wood, managed to do quite a large number of things. I always feel like it's a bit of a fatal moment when you say, and it's a commentator's curse moment, isn't it, when you say, and nothing's gone wrong, but you were telling me this morning that we had another upgrade overnight or this morning which had gone without a hitch. So I'd be really grateful if you could pass back our thanks to each and every member of the team who has worked to make all of this happen. It's really important stuff. And we will need to come back to it because, as David said, digital is an increasingly important capability for us to have as an organisation. But thanks to you and the team, AG.
Yeah. I think probably in terms of capacity, it's a very good question. We're obviously prioritising priorities. Keeps coming off.
Digital problems.
Not one of mine, thankfully. And it will be a challenge throughout the year. And I think as a trust, that's going to be part of our digital challenge going forward.
Thank you, Dave. Thank you. And say, again, echo Simon's comments regarding thanks to the team. And thank you for your contribution as well, AJ. Right, moving on. If I'm correct, we've now concluded the main items of business with slightly 6 minutes over the schedule. So it must be one of our better performances, that, in terms of getting into our leadership way and evaluation of the meeting. Just to check with the Chief Executive, we've not missed anything? No, that's good. That's good. Yeah, we're in good form. So, colleagues, in terms of evaluation of the meeting, there's been a lot of positive stuff, sure, we've heard, and I think it's important, though, when it hasn't just been a procession, as it were, of congratulation. Have we been compassionate, or have you been compassionate in your questions? Have you cared about patients and our staff? Have you been curious? Some of you have clearly done your homework and read the performance report from what I was hearing, but have you been curious, and are we being collaborative with each other, but also with our partners in the wider health and social care system? So, questions, please, or comments rather. Has the meeting achieved the objective? Okay, that's great to hear.
Should we, just before we go into A or B, should we just do the questions from the public first?
Yes, absolutely. Yeah, questions. Any items from our members of staff and any members of the public present related to the matters we've discussed on today's agenda? Because this is a meeting in public, and we do take questions from the floor regarding the items on the agenda. So, can you say who you are, sir?
Yes, my name is Harrison. I'd like to ask a question.
Yeah, is it related to the business of the day? Yeah. No, you can do it from there if you, as long as you project your voice.
Well, thank you all for the opportunity to address you all today, and some very interesting listening. My name is Harrison. I'm a local councillor in Elbridge, in Surrey. I'm actually here to ask for the question linked to the financial aspect of the agenda, specifically the deficit that was mentioned earlier, and the initiatives to help alleviate financial strain. My question surrounds the board's receptiveness to potential fundraising initiatives. With recent reports highlighting a gloomy financial outlook with projected increases in fuel and insurance costs set to exceed £72 million this year, a staggering rise of 56% in insurance expenses alone in the UK for the Independent. In response to this alarming trend, I reached out to discuss a fundraising initiative aimed at alleviating these financial strain. This initiative secures essential funds for the services, but also utilises vehicle space to disseminate vital purposes.
Excuse me, sir, this is not an advertising pitch. Is this what's your question, please?
Well, I'm getting to it.
Yeah, can you come to it? Because I think you've been in touch with us before. This is not a place for traders or businesses to make a pitch for their business. This is an environment to ask questions about the business on the agenda. So can you come to your point? Well, we haven't got we got other business to transact. So if you could get to the heart of the matter fairly quickly, please, that would certainly help.
So, look, I mean, thank you for your question. Look, we're obviously not in a position to respond to it in the context that you've raised. If you've raised a question with us previously, all I can do today, and this will have to close this matter here, is to say we will undertake to come back to you with an answer. So, thank you for your question. And that's where.
Can I wait to maybe pass my details on to you?
I'm sure you can leave. I'm sure you can leave your details here. That's absolutely fine. That's as far as we can go today.
Please leave your card, but we're also bound by public sector procurement rules, and there is a way of actually pitching for business, and we put items out for tender as required. So we thank you for your interest. Harvey.
Right. Can you all hear me? Yes. My name's Harvey Nash. I'm a public governor for Sussex Lower, or West Sussex as it's sometimes called. Three quick things. One was just to congratulate everybody in CCAM for what's been achieved over the year. From a public perspective, that's vital. So the achievement of the Category 2 challenge is greatly appreciated by the public, and I know that colleagues on the Council of Governors are equally impressed. And that's a team effort. It's not just the guys on the trucks, it's the people in the EOC taking the calls, and it's all the people behind making sure that the trucks run, the people get paid, etc. So just thank you. One thing on the CAT 2 target, we talk a lot about that, and it was something that came up in a meeting that the council had recently, talking about the strategy. Yes, Category 2 is potentially a red line. We need to achieve it. From a public perspective, though, they're kind of interested in CAT 1 as well, because that's kind of more serious. So when we talk about achieving CAT 2 at 30 minutes, we need to reassure the public. It's just in the message we send out. And finally, just from a personal perspective, and I'm sure my colleagues agree, thank you to David for a really good job as our chair. Your openness, your honesty, your engagement with the Council of Governors, and your support has been absolutely immense and deeply appreciated. So thank you. And just as the last thing, you asked for this parting gift of action on appraisals. I think you'll probably note that I'm still here and I'm still going to be asking about appraisals. So If Simon doesn't do it, I will keep nagging him. But thank you.
For your kind comments. I think Emma, do you want to give some assurance on category 1?
Yes, thank you, Chair. And Harvey, it's a really fair point. Just to be clear, and it's also not just category 1. We have 4 categories, of course. Some of our biggest harm is our lower acuity calls, particularly elderly fallers, where they sit on the floor for a long time and we don't get to them. So all of our patients are important to us, whether they're in category 1 or category 4. We look at this, I look at this like every single moment of every day, but we actually report on this and we talk about this a lot. And actually, if you look at our performance over the last few months in particular, not only has our C2 continued to improve, but I can tell you, relative to other ambulance services, our C1, our C3 and C4 have improved both in total, in numbers of seconds it takes to get there, but also relatively compared to previous. And just as an example, C4, we used to very much be at the bottom of the table, and we were 3rd in February nationally for that. So we absolutely look at all patients, but you're right. I need to talk a little bit more about the C1s, 3s and 4s as well. I understand.
But without prolonging the matter, one of the things I know non-executives we picked up in talking to staff in Ashford was the fact that we were now differentiating the calls. We were getting to category 1 calls quicker in that area because of the strategic approach which the team are now taking. So I think there's certainly hope for the future. We'll hopefully see that continue to improve over time. Okay, thank you. Any other items of urgent business?
David, I'd just like to say a few words, if you don't mind. I mean, you mentioned earlier that this is your last public board, but you will be with us, thankfully, for at least another month. But I just want to say a few words of reflection and, to be genuinely thankful for all that you've done. If I start by saying the career that you've had is incredibly impressive. I mean, you started as a hospital porter, I believe, in the age of 17, and here you are now as chair of CCAM. Listen, I wasn't going to say that. I was being a bit much more polite about 71 next week. 71. But the important thing is, if you look back at what you've achieved, you became chief executive of a key London hospital trust, St George's. You went on to manage a major business in the Middle East. And I like to think that CCAM was the creme de la creme, the top of the pile. That is a really good one to finish your formal career on. But I mean that genuinely. And I was also reflecting this morning on my drive here about you joined in September, I think, 2018, and I came in 2018. And the only people I still recognise from that day in the room are Janine, you and Peter. And I was reflecting on the journey that we've been on over the last 5.5 years, and I was trying to think of the adjectives I could use to describe that. I came up with fun, because I think it has been fun, but I also think it's been incredibly challenging. We've had lots of issues to deal with, and I think the mettle of the person is how they respond to those challenges as a leader. And what I would say that has been 100% consistent, and others have said this, is first and foremost, your focus on patients. I don't think you've ever stopped by saying ultimately what we're here for is to deliver a service to patients. You've been very clear as well about your commitment to CCAM people. Having worked in the NHS for many, many years, I think you really get the pressures that our colleagues face and the emotional trauma that they can experience in delivering healthcare in often very difficult situations. So I think your ability to show as a leader empathy has been impressive. So I don't want to embarrass you much more, but I think we owe you a considerable debt of thanks, both from the patients that CCAM serve, our system partners, and I have to be clear to you that a number of system partners at NHS England and the ICBs have reached out to me and been very clear how much they valued your contribution as a system player over the last 5.5 years. I think CCAM people value you and genuinely would want to say genuine thanks. And finally, as a board, you've been great to work with, you've been very supportive, and I say that on behalf of the executive, those who are not here today. I say that on the whole of the NED community that is here today, but not only the NEDs who are here today, but if you think back of those who have been with us in the past, Lucy, Terry, Al, Angela, a whole range of people, and if anybody, and of course Tom, who's recently retired. So genuinely, tremendous thanks. And the final thanks, I think, is I don't think you could have done this without the support of your family. And I know she's not here today, but I hope you will take home the extended thanks from the whole of the board for the support that Denise, your wife, has given you in enabling you to do this. It can't have been easy, given the number of times you've been out on the road, all over the CCAM footprint. And I think the other thing I'd say is there's inevitability of reflection. What legacy do I leave? And, I said about that journey, we've got a really good strategy. Culture's changing. I think CCAM's in a very good place, and I think you've made a significant contribution to achieving that. And I'm pleased to know, I think your son's a paramedic as well, isn't he?
Yeah,
So,
try not to say too much. I remember saying, you are putting a seatbelt on in the back, aren't you, son? I did say that to him a few weeks ago as well, but try not to take work home with me, but I didn't want him to get into too much trouble as well.
But we wish you well, and I'm really pleased. I'll be thinking about you on Cunard in a couple of months' time,
Yeah.
and also when you're sailing in Australia. It only leaves with me to give you the inevitable thing. It's a bit like the Oscars. I think you've got to have the CCAMs.
Oh, we get the shields.
Yeah.
I've given enough of these out, as it were. So. Oh, bless you.
Here's
Thank you
the
very much.
shield.
Thank you.
And also for your wife.
We'll do.
I hope you can take these home.
Oh, that's very good. That's lovely. Actually.
But I think Simon, it's a double act here.
Yeah, I mean, Denise, with apologies, she was asked to be here, but she doesn't like fuss, but B, she's gone to she's at a theatre matinee in Bromley this afternoon. So I'm sorry, but that was probably with her mates. So there's probably more importance.
Watching, I think, an Agatha Christie.
Yes, Agatha Christie.
Bizarrely enough.
Yeah.
We're just trying to sort out the flowers. So it falls to me to say the final thank yous. I mean, I think everybody would observe, and those of us who've done the job know, that the relationship between a chair and chief executive is critical to the success of the organisation. It's a partnership, but that really doesn't do justice to what's involved in helping a chief exec do the best they can and helping them be the best they can. And I've known all sorts of chairs, but I couldn't have wished for a better chair coming to CCAM. And the things that I've been able to do this year have in great part rested on the wise counsel, the absolute personal support that David has given me. And it's not often visible to many people around this table, because most of those conversations, by their very necessity, they take place in private, and so they should. And the value that you get from that relationship, that being able to be yourself with somebody else, in this case somebody else who's done the job, I can't tell you, colleagues around this table, how much that has meant to me and how much it has enabled me to do what I have done during the course of this year. And all of us, David, know your passion for CCAM and how much you care about it. And I think the sincerest tribute that we can pay you is to promise you that not only on appraisals will we continue your legacy, and I am fully expecting Harvey to honour his promise, but we will also continue your legacy and I think this is probably your biggest legacy, your kindness to people, to the organisation, but most of all to our patients, I think is something that all of us who have worked with you will remember. So can we just say thank you to David in the time-honoured way. There is one, before you say anything, you need to turn your mic off here just because we're going to Hi, Mike. Before there's a couple more bits that are a bit more audio-visual here. So here, I think, is the first of those. Kindly supplies by... Can we put that back up again? Is that all right, please? Just the photos. Thank you. There are some personal favourites for us all there. My particular favourite, I think, is the mafia boss escorting Lester Piggott.
Can I just share that? Just to share that, as it were, that's taken when my daughter was very tiny. I was then the general manager of Addenbrooke's at Cambridge, and Lester Piggott, as you'll know, the world famous jockey, had been incarcerated at Her Majesty's pleasure as a local prison. This for tax evasion, tax avoidance, or whatever the right term is. And his wife was admitted to Addenbrooke Hospital, his then wife, having sadly fallen off a horse. Described by the regional communications director, then we only had 2 people for a region, for the whole for communications, described that Mrs. Piggott was in a stable condition, which went down terribly well to the journalists on the front part of that. But there was I learned a very important lesson. Is there's some things you don't get involved with the boss. And there's sometimes you need to delegate. And no matter how much people persuade you, you need to have the strength to say, it's not me, I don't think I need to be involved in this. Somebody else is better able. And I was persuaded this top secret visit by Lester Piggott at 10:30 at night from the jail in Haverhill to Addenbrooke's was going to be top secret, and only I should know as the unit general manager. And the deputy regional communications director assured me nobody else knows. He's coming with the deputy governor. And on the back road of Addenbrooke's, we welcomed Lester Piggott out of the car. And then out of the bushes came Fleet Street's finest. And then they had flashbulbs, and it was a long time ago. And we were pursued through the hospital, Lester Piggott, me in tow. And I forgot my tie was undone because I've been nursing my young daughter at home. And Anne Diamond on breakfast television described it. Oh, here's a picture of Lester Piggott with the security. So I've never lived it down. But I think the other thing that you have to have in any kind of leadership role is you've got to have the ability to have self-deprecate and to have a sense of humour. So that was one where I was tested. I got the biggest telling off ever in my career by my bigger boss, as it were, at the time. The moral is, if you shouldn't be there, don't be there.
And just one more little surprise before we close today.
Hi David, it's Graham Stewart here from Everton Football Club. I just wanted to send you a message on behalf of all of us connected with Everton to wish you a very happy retirement. 50 years of service to the NHS, obviously every credit in the world to you for all the service that you've given to many a person, I'm sure, over the years. And time to put your feet up and relax and enjoy the rest of your life. Wherever that journey takes you, we wish you all the very best, mate. Thank you so much for all the support that you show us as well as a football club, and hopefully we'll be safe this season. I know it's been a tough one for all of us, but hopefully we get the wins that we require to stay up and move down to our lovely new stadium at Bramley Moor Dock as a Premier League football club, so you can enjoy your retirement watching the Blues. Take care of yourself, David, and thanks again for all the efforts you've put in over the years. Take care, mate. Bye-bye.
I do thank you warmly for that, and that's very touching. I'll just go back to what Simon said. My first day. I was introduced to a gentleman called John Nolan, who was a colleague porter, and John was a retired merchant, a former merchant seaman who'd seen life for shore. And I always remember the first words he said to me was, "Stick with me, our kid, and I'll look after you." And I've always remembered that. And he did look after me on my first day. I was absolutely terrified. absolutely terrified. No induction courses, no lifting, handling training. You're just given a coat and told to sit still, usually with a few expletives, and you'll be given a job in due course. And I shadowed him for the whole day, and he took me some, helped me with some quite difficult scenes, including, literally the first morning was a ward for the patients having electric shock therapy. And he was my guide, as it were. And I learned from that actually colleague support is what matters, and we're a team. And wherever you do, we all play a part. So I'll say I'm very humbled by this tribute. Thank you very much indeed, and thank you, Michael, as well. I recall the interview for Michael. I wasn't part of it just before I was appointed. I was officially in post, rather, and I was outside the Liverpool Women's Hospital, and having to persuade the Council of Governors between two admirable candidates. But I could see that having a retired Chief Operating Officer of the National Audit Office was going to bring certain gravitas to the board and elevate the audit committee from to a more strategic level. So, Michael, thank you, and thank my non-executive colleagues in particular, but also the executives. And just a final point, I always tried to be the chairman I'd always want to be if I was a chief executive, and I had some great role models, I have to say, in terms of who were very supportive to me personally in my time as a leader, as well as other leaders. Also had one or two that it wasn't easy, and I was always determined to be one of the better ones, and not someone where my chief executive was saying to me or implying to others that it wasn't easy working with him. So thank you for that, Simon, and I thank you for what you've done and what the executives are doing. So I think it's time for lunch, isn't it? So thank you very much indeed. Thank you.